I'm Madeline Ruff. I'm the telehealth project manager for Appalachian Regional Healthcare in Kentucky. And we are looking to start a virtual nursing program, and so that's why I'm here.
Awesome, awesome.
I'm Kelly McDermott. I'm the Chief Marketing Officer for Caregility, and I am here to hear Wendy speak along with the rest of the panel and take lots of copious notes.
All right, all right.
Hi, I'm Corey Morrison. I'm from Cincinnati Children's. Yes, I know that's in Ohio, but we're right across the river from Kentucky, and we get patients from all these states. Virtual nursing is something that we've been talking about and thinking about for some time, so I'm really interested to hear what you have to say.
All right, good.
Hi, I'm Lorraine Valeriano from Allentown, Pennsylvania, Lehigh Valley Health Network. So I really came to see you, but no, that's not completely true. So I oversee the tele-ICU in our network, and we're looking at ways to expand that reach. And I know there are many tele-ICUs that do that, but we're not doing that yet. So I think it'll be really helpful to kind of focus on virtual nursing for expanding our tele-ICU.
Great.
Hi, Cindy Diaz, Johns Hopkins. We are just starting to look at virtual nursing. Hi, Lori. And really interested if you all are sharing anything about KPIs, so we're just interested.
We will share a little bit about that. Darn, that Wendy's very popular.
Hi, I'm Tina Gustin. I'm from here. I have two hats. One is at the Children's Hospital of the King's Daughters, and I was sent by that team to come here. And I'm also faculty at Old Dominion University, where I'm the director of our Center for Telehealth Innovation, Education, and Research.
Oh, nice. That's a lot, yes.
Hi, I'm Rhonda Gregg. I'm Chief Nursing Officer for Reconnect for Health. We're a nurse-owned, nurse-operated, and run telehealth monitoring program. I am old, so I pioneered one of the very first remote monitoring programs outside of Philly in the mid-1990s.
Wow.
So when I used to work here at Centera, I was lived here years ago, started a lot of programs at Centera Home Care too. So I'm here because I'm just anxious to hear what all's going on and what you're doing.
Wonderful.
Good afternoon. I'm Janina Rogel with Amwell. I'm actually local to Norfolk, so if anybody has any questions, I'm happy to help you out. The number one concern that I hear just from talking to different individuals is a labor shortage, especially when it comes to nurses. So I'm very interested. I am not the virtual nursing rep for Amwell, so I'll just disclose that now. I'm a safe person, but I'm very interested just to see like how are folks thinking about solving for this challenge.
Hello, I'm Garrett Taylor. I work with Caregility. I'm a sales development representative there. I am here to support Wendy and be a sponge and soak up everything virtual nursing.
Great. We're just introducing ourselves so we get to all know each other. We're going to spend a long time together this afternoon. So,
Mark Bingham. I'm from Spartanburg, South Carolina, which is upstate South Carolina. I am the medical director for telehealth, also in charge of clinical informatics that includes nursing informatics. So we have a big interest in virtual nursing, but have done none of that so far.
Great.
Hey, I'm Santana Green, nurse practitioner with our telehealth team, also from upstate South Carolina. So I'm here along with Dr. Bingham to also look into virtual nursing and see how we can possibly incorporate that.
Awesome. All right. Wow, what a great group. This is going to be fun, I think. And we have a wonderful panel. By the way, this panel and I have known each other for many, many moons. In fact, Cindy Welsh and Wendy Dybert and I, we were in the very early days of the EICU, then called tele-ICU, now known as telecritical care. So it has morphed in its knowledge, its terminology over time. I had the pleasure of working as a staff nurse in the first tele-ICU on the West Coast, the second in the nation. We opened our doors in January of 2003. And then in 2004, I became the day-to-day operations manager. And about 6 or 8 months later, my mentor, the director, left. And so here I was, a brand new manager, and I became the director and had to learn the sink or swim method of how to be a director with the reporting structure that went up to the vice president of integrated quality and the chief medical officer of the region, who reported to the CEO of the entire health system. And this was Sutter Health, so it was a very large health system. So I lost all that, you know how when it runs downhill, as they say, it goes through all those filters before it gets to you as a manager. Didn't have any of that filtering. So it was a lot of fun. It was challenging, but it was a ton of fun. And then Fiona Winterbottom and I became acquainted over sepsis work as well as virtual nursing work over the last, decade or so. And so we've worked together for a long time, and you'll hear more about them. They're all from different places. And we hope that you enjoy our presentation today. And so by the end of this session, we're hoping that you'll be able to describe the who, the why, the where of current and projected nursing shortages. I heard a few of you say that you're interested in those nursing shortages and learning more about kind of where we're going in the industry with that. So we're going to talk somewhat about that. We're also going to think about knowledge management. So knowledge management is a conceptual framework that looks at an organization or a practice and how well we manage our knowledge. And we know that there's inadequate knowledge and lack of experience, unhealthy work environments that are all contributing to these high turnover rates. Right? We have new nurses starting at the bedside, and the most experienced nurse working alongside them has 1 year of experience. So they have no expert to go to. We're also going to summarize the various roles and responsibilities of the expert nurse that can be extended remotely. And that's really one of the essences of using virtual nursing, is how do we take that knowledge and manage it better across geographical boundaries, right? We don't have to be in the same hospital running from unit to unit. We don't even have to be in the same city or the same state, right? These nurses can be literally anywhere in the world. And then we'll look at some of the clinical and financial implications of having a virtual nurse program. So hopefully, what many of you said you're here to find out about, we'll be able to talk about that. And here's our disclosure slide. So several of us also do consulting outside of our normal jobs. I am a consultant for Blue Cirrus Consulting, so I get paid to help people, so I have to disclose that. That's what I do. That's my everyday work. And then I also do other work with Vivint Health, Baxter Health. Fiona is also works with Baxter Health, as I do as a clinical advisor. And also is on the speaker bureau for Zoe Medical. Wendy works for Caregility, so that's her disclosure. And Cindy has no disclosures. So she's the most unbiased of us all. But we'll try to put our biases aside, as we are trained to do. And a little bit more about me is I'm also an assistant professor at the Graduate School of Nursing at the UMass Chan Medical School, and I teach bioinformatics and quality there. So for me, these are the things I'm going to cover. I'm really going to get into the industry trends. I'm going to talk to you a little bit about the virtual nursing program and how it can close gaps and reduce nurse turnover, and describe some of the metrics. I know a few of you wanted to know about metrics. So here's some stuff we know. We know that registered nurses make up the largest number of healthcare providers. They are in the world, but we know also in the United States, across the country, and they do this in the hospital setting and in the long-term care areas. We see nurses at the highest number of professionals working with patients. But we also know the ICN estimates that globally, 13 million nurses will be needed to fill supply and demand shortages globally. So across the world, we're going to see this huge need of nurses, more nurses. And then when we look at the Bureau of Labor Statistics from the United States, we can see that as RN jobs opening, we will increase each year by 203,000 nursing jobs that we're going to need. 6% increase year over year. So this is the problem, okay? This is the problem. And as we mentioned earlier, some of the contributing factors are lack of potential educators, high turnover, inequitable workforce distribution, heavy workloads, inadequate resourcing, burnout, and stress, right? We've heard these before. This is nothing new for you. When we look at this paper by Haddett et al., we see the aging population is also contributing to that. Anybody in this room a baby boomer? I'm at the tail end of the baby boomer. I hate to admit that because now you know how old I am, but I am at the tail end of the baby boomer age. And so we're seeing this 73% increase in Americans over the age of 65. And as we age, we end up with more comorbid conditions, right? So we have sicker people, older people. We also have an aging workforce. Over a decade ago, our nurses, on average, were 45, 50 years old. Okay, so now they're 55, 65 years old. And so they're retiring at high number, and we're losing that knowledge when they retire that they take with them, in addition to this increased turnover that we're seeing for other reasons. Career and family nursing is still predominantly a female industry, and when women start to have children, many times they leave the industry for a few years or so. Sometimes they never come back to nursing, sometimes they do. We have regional population growth where nursing shortages are going to vary, and I'll talk a little bit more about that. And then we have this violence now in the healthcare setting. It's awful. I mean, nurses are being harmed violently. We read about it every day. We get the safety reports at our hospitals every day that our caregivers are being violently attacked and assaulted or verbally assaulted on a daily basis. And then they don't want to be in their careers anymore. Those are the references. Every one of these slides, I'll drop in references so you can go and read the material yourself and find it, because if you're trying to build one of these programs, you need the evidence to go back to your leadership and show them, and that's why I always include multiple reference slides for you. You will get a copy of these in a PDF format that'll be sent to you. So during COVID-19, health systems sought all kinds of different ways across the world to figure out how to increase the number of caregivers rapidly. We pulled nurses away from the long-term care side because we needed more in the hospital. So we left them struggling, right? But the workforce was stressed beyond it could even have imagined during the pandemic. And this was a graph I found showing the global problem of nursing. So in yellow, you see, In yellow, this is nurses shortage. In red are the medical doctor shortages. And you can see by country how big these shortages are. Okay, so these are massive shortages that we're going to be seeing worldwide. And when we look at it at state level, we can see some of the most severe shortages are going to be in California. That's because they have those mandated ratios. And what they did, I was practicing in California when we implemented those ratios. We stole nurses from literally all over the world and all over the country because we have very high salaries in California as well. So we stole them away from other places to fill our gaps. And to me, that I'm very global thinking. That's problematic, right? If I'm taking nurses from one place to put them in another place, I'm creating a problem of care somewhere else. And I have family members that live all over the United States. So this is a problem. But we're going to see these shortages continue. So you're going to see the demand by 2030. This is how many nurses are going to be needed, and this is how many the supply is. And this is actually relatively old data. It's a few years old. It was before the pandemic. So these numbers are probably much higher than what I'm showing here. And this, how many saw this report? Just came out on March 8th. See this? So over 2,000 nurses by nurse.org were surveyed, and 60% love being a nurse. That means 40% don't, by the way. That's a lot that don't love being a nurse, right? That's a problem, right? 62% are concerned about the future of nursing, right? So they're thinking, oh my gosh, what's going to be next? 39% are dissatisfied with their current job. That's probably the 40% that don't like being a nurse anymore. 91% believe the nursing shortage is getting worse. 79% report their units are inadequately staffed. And 55% say they saw a pay increase, but 75% they still felt underpaid. So whatever increase they saw, they didn't think it was enough. So these are all factors that are building into this problem that is not going to be solved just because the pandemic went away. It's not going to go away. So what's virtual nursing, right? Some people think, well, how in the world can a nurse practice virtually, right? They're not touching the patient. How can this be? Well, they work in a remote area, a controlled environment usually, and they observe and respond to clinical alerts. We call it surveillance, and I'll define surveillance a little bit later. They assist with tasks that do not require physical proximity. There's a lot of things we do with patient care, like education. When I educate a patient on something, I don't have to be close enough to touch them to educate them. I can do that. There's many things that we do that we can do from afar. I can assess a patient. In 2003, when I sat behind the camera as the virtual nurse in critical care, I was assessing the mechanical ventilation of the patient. How well were they responding to the settings that we had on that mechanical ventilator? I could observe the monitors. Any monitor in the room I could observe. I could observe the IV pumps. I could zoom in and read the label if they didn't label their pump, where I could see what the medication was. I could read the dosages that they were getting. I could figure out if the patient was breathing synchronously with their breathing machine. I could look at their nail bed. I could zoom all the way in at the nail bed and do an assessment of nail bed color, which tells us about perfusion. These are all assessments I could do from 500 miles away, because we had literally a 500-mile square radius area we covered, so some of them were that far. And then we can act as knowledge translators for evidence-based practice. So we have this really interesting concept in healthcare. And I don't know that if this is in every other industry, especially I don't see it in very complex industries, high reliability organizations. We expect every nurse and every physician and whatever the role is, to be an expert at everything. There's too much to know. There's no way one human being can be an expert on everything. And so we have to have knowledge translation. And then we can guide practice patterns virtually. So what are some of the models and tools we might see? Well, you can see a centralized model where everybody sits in the same room, right? And they're providing care remotely to patients who could be anywhere in the state or the country or the world. And they're using a plethora of different technology tools, but they're all sitting together and practicing together. Or they could be decentralized. So they could be talking to each other using remote communication tools, secure messaging. They could be doing video calls back and forth with each other, or calling in someone to come in a room with them virtually, but they're not even sitting in the same room. Or they might use a blended model, where they use a little bit of both. We know there's lots of audio-video solutions we can use. We can use cameras that are mounted on the wall with one-way video, although that's pretty old technology. We should be moving everything to two-way at this point. There's a lot of reasons for that, right? What do we do in prisons? We have one-way video. So the guards get to see the prisoners, right? They can see everything they do, but the prisoners don't get to see the guards and what they're doing. Right? It really puts us at a disadvantage if you're on the side of the camera where you can't see who's looking at you. So it does create some problems with adoption. We found this out the hard way because they only had one-way video when most of us started, right? And we learned that the hard way. So two-way audio video is what you want to have, but you can do that over a telemedicine cart. You could do that over a tablet or an iPad or a smartphone. There's many different mobile technologies we have options and choices for. Here's a bunch of references. Again, when you get these slides, you can go through and figure out where I found a lot of this information. And you can see that up here, there's Cindy and I. We got the chance to write about tele-ICU interdisciplinary teams. I got a chance to serve on this task force, and I'll talk a little bit more about the AACN consensus statements. And then some other papers on looking at the impact. This paper that I did with Ruth Kleinfeld several years ago. Lisa Mae Williams, this is two excellent papers by her. And then we've got Sandy Aronson down here from Atrium. So really good resources if you want to learn more about virtual nursing. But we'll talk a little bit about this one. So this one actually started many years ago. I want to say the first one was in 2010. That we got together, and it was called the Tele-ICU Acute Care Standards, right? Standards document. And then the next version that came out, we changed it to the consensus statement because really we're critical care nurses, so we follow the same standard of practice in acute care or critical care as any other nurse. So we were like, why are we having like a separate standard? It's the same thing. We're just using virtual tools to extend our practice. So we decided to change that. And so this document, there's a reference there where you can find it. And then the other one that's really important, it's embedded in that consensus statement, is the healthy work environments. And that has been around for a while now. The American Association of Critical Care Nurses was also instrumental in this. This is their document, their model that they developed, looking at all of these different components or standards: skilled communication, true collaboration, effective decision-making, appropriate staffing, meaningful recognition, and authentic leadership. And I wanted to highlight this one because we're going to talk about that one next. It's all about an effective match between the needs of the patient and the competencies of the nurse. And there's a model for that too that we'll talk about. But you can see they did this recent study here, survey, and they looked at intent to leave based on whether or not the healthy work environment standards were implemented. And when they were not implemented, there was a much higher, almost double, really double the amount of nurses wanted to leave. And I'm going to talk about this because this is going to be one of the metrics you're going to want to measure, and we'll talk about that later too. So this will all tie together. And then appropriate staffing and perceived patient quality of care, and then this thing called moral distress. Has anybody ever heard of moral distress? It's when you get stuck in a situation where you have to make a decision and neither decision makes you feel right ethically. Both decisions make you feel uncomfortable. And so one example of that would be, I did another study on titratable medications, and the Joint Commission came out with some rules that you had to have very stringent order for everything that you would do with titrating a medication. And when we surveyed nurses, what we found were nurses were saying, I don't know what to do. Do I go ahead and do what I know I should do, because we've been responsible for titrating these medications for decades? So do I do what I know I should do because the patient has no blood pressure? They're literally going to code and die. Or do I stop what I'm doing and call the provider and wait for them to call me back to give me the order to make the change, which they're going to ask me, well, what would you do? And then I will tell them what I would have done, and then I'm going to do it, and in the meantime, the patient's coding, right? So that created moral distress. And so that's an example of moral distress. And so when we look at that telecritical care nursing model, it's based on the synergy model. And I brought that up. That is when the competencies of the nurse need to align with the patient's need throughout the continuum of care. So novice nurses, when we put them in a situation to care for patients, their competencies may not be aligning yet. So they need to have skill mix on the unit so that they have a mentor to go to help them. When I started as a critical care nurse, I was a new grad RN in 1997, and I had about 90% of my staff had at least 5 years of experience, and many of them had more than 20 years. About 70% of those had their advanced certification in critical care from the American Association of Critical Care Nurses, which I ended up getting a year and a half after becoming a critical care nurse. So I had tons of resources to go to from an expert standpoint. That is not the case anymore. These nurses, as I mentioned, the most senior nurse might only have 1 year of experience, and they're already in charge in a critical care unit, in the ED. Used to be you had to work on the floor first, and then you could go to the ICU for a couple years, and then you could be an emergency department nurse. They have new grads in the emergency department now. So this is why we need expert nurses working virtually. When we look at the AACN healthy work environments, we can see that those are here. Authentic leadership is built into that. Skilled communication, true collaboration in the model. We also want to make sure our foundation is on equity, diversion, and inclusion. And our goal is to get optimal patient and family-centered outcomes. So that's our model that we've developed. And really in 2022, we we added this layer here. But this model was developed, I don't know, probably a good almost 8-10 years ago. All right, there we go. So here's what we've been talking about. We have a huge problem with lack of expertise, right? We have a huge problem. And this inadequate knowledge, lack of experience, and unhealthy work environments contribute to errors that harm patients, moral distress, and subsequent nurse turnover. So if you think about it, if you're a new nurse working on a unit and you make a mistake and the patient is harmed, maybe they're harmed to the point that they code and they die. So not only have we lost that life or injured that patient, we've injured that nurse. That nurse is injured morally, ethically. And what we see is nurses have these catastrophic mistakes. They leave nursing, and sometimes it's not only career ending, it's life ending. They commit suicide. They take their own life because they have such moral distress over what has occurred. And so we have to fix this problem for multiple reasons, for safety for patients and to preserve our nurses and to support them. But expert nurses, on the other hand, are equipped with situational awareness and pattern recognition. They can walk into a situation, and because they have so much experience, they can look at everything that's going on and they can analyze, evaluate, interpret what's going on, and they immediately know what needs to be done next. Novice nurses can't do that. And then that expert nurse can do a therapeutic intervention, and they're again interpreting those patterns, they're recognizing what's going on with the patient, and they know exactly what to do next. And they're titrating, if you've ever seen those pictures, right, of the ICU room, especially, or in the ED, or the really complex patient. But this happens everywhere. This happens in home health nursing. This happens with RPM, right? If you have an expert nurse managing those vital signs coming in, it's not just the system that's helping them triage, it's their situational awareness and their experience that tells them, I need to get on the phone with this patient. I need to check them out. I need to make sure they're okay. And so this is what we need. And this nurse knowing is hidden. Okay, Patricia Ebright calls it this hidden nurse knowing cognitive stacking. That's what she referred to it as. And I've got more references for you, so you can go look those up and realize I didn't make this up, right? I actually did my homework. So what can a virtual nurse do? Now that we went through all of that, what can they do? Well, they can do admission and discharge navigation, right? You don't need to be touching the patient to fill out the navigators in Epic, or what are they called in Cerner? Is anybody Cerner? I don't know what they call those, the documentation pathways for admission and discharge, but you can fill those out. You can improve those transitions of care, which are really important, and that's again why you want an expert nurse. Right? Someone who is really good at admission and discharge is going to make sure that we start teaching the discharge teaching at the time of admission. They're not going to wait till an hour before the patient's going to go home to start teaching them. They're also going to do a better job at med reconciliation and some of those tasks that are associated with admission, discharge, patient and family education. They're able to do that, and they have done it for years at the bedside, so why not do it remotely? Best practice surveillance. This is a big one, and we'll talk more about this as we go through here because this is so important. We want to ensure that we're all adherent to the best practice measures, quality indicators, and evidence-based practice initiatives that we might be putting forth in our organizations because we know that's going to provide better, safer care. So we can use expert nurses to oversee that, to ensure that, instead of, again, like I said, expecting every nurse to be an expert at everything, we can have these folks doing that. And we'll talk a little bit more about surveillance in a minute. I spoke about med reconciliation, but we know this can reduce adverse drug events. So what I'm telling you here is when you're thinking about doing virtual nursing, you have to decide which one of these problems is the most important problem to solve. I'm not saying you should implement all of them. That would be crazy, right? You can't be successful at implementing everything at once. But which one of these problems is the biggest problem you're being faced with in your organization with your nurses? You pick one of those, and then your metrics, of course, are going to follow. But you first need to understand that problem. And we know that med reconciliation is a big one. Patient-family education, improving that health literacy, right? Some people do that really well. They're naturally good patient and family educators. Other nurses aren't as good at that. So why not put somebody in the virtual nursing role that's really good at that and have them do all the education, right? And so we want to make sure that our patients are adherent to their own medical conditions, instructions, management, self-management. We want to teach those kind of things. Care coordination. When we have a clinically complex patient, we try to rely on case managers. How many people have a shortage of case managers? Right, we don't have enough of them, right? We're always waiting for the case manager to finally see the patient. Why couldn't they do that virtually? Instead of having them go from bedside to bedside, why can't they go virtually from room to room? So we can do this in multiple different ways using different team members. And then those on-demand services, the patient just has a question. Right now, they hit the call bell, they interrupt the busy nurse who has to run down to the nurse assistant, and then they start asking questions. Well, if you've already got a virtual nurse who's been helping with your admission to discharge process, they already know the patient, they're doing the education, they can hit a button and boom, they have a nurse virtually available to talk to them. You're not interrupting staff who are doing something important. And every time we interrupt somebody when they're doing something important, we increase the risk of harm to patients. That's been proven. So again, this is a quality and a patient safety initiative. Again, more references for you that'll be available for you. So a virtual nurse program ensures that nurse decision-making is optimized for execution of safe and effective patient care throughout the care continuum wherever the patient is located. It doesn't matter. When I started as that virtual nurse at Sutter Health, we covered over 500 square miles. We had 24 acute care hospitals. We had 5 hospitals that were considered critical access hospitals. One of the hospitals that I would monitor patients at was literally on the California-Oregon border on the coast. They would have to drive 2 hours, hour and a half to 2 hours to get to Medford if they had a patient who needed to go, because they couldn't come down to one of our other hospitals. I mean, I think that the closest hospital was 3 or 4 hours away, California Hospital, that had, that was a tertiary care center. We'd have to fly them to get them down to the Bay Area, because it was literally, when I went to visit them, it was either 7 hours flight or a 7-hour drive, because you had to go stop over and do a layover in San Francisco from Sacramento if I was flying from Sacramento, and then you'd finally get on that plane, and then you get there. It's about 6-7 hours. So when they have difficult weather there, they can't fly out. So they would have to care for those patients there. So it shouldn't matter where the patient is. We tried to do this regionalization, of critical care. I don't know how many of you remember that. Oh, all patients who are critically ill should be at a tertiary care center. Well, you can't do that, right? There's people who don't live near a tertiary care center. So we have to be able to care for them where they are. Has anybody ever heard of ISR, Intelligence, Surveillance, and Reconnaissance? Right? It's a big military term. It's commonly used in the military. It's defined as coordinated acquisition, processing, and dissemination of accurate, relevant, timely information and intelligence to support a commander's decision-making. What if we use an ISR model for nursing decision-making? What if we did that? Could you imagine how much better the care of the patients would be, because we would have experts who were trained to do surveillance, intelligence gathering and surveillance, and then they could provide back to the reconnaissance team exactly what's going on, or report back to them and help guide the care of the patient. Something to think about. So let's think about this. Here's another reason why you'd want to do this. This is one ICU. I'll tell you, it was at UMass, okay? They asked me to do a talk on alerts and alarms. And so I said, well, you got to send me some data. I want to evaluate your alarms. So this was their alarms. 178,000 alarms in 1 month, bedside alarms. 178,000. Now, part of this is because we have to do a better job of tweaking our bedside monitors and the alarming functionality, but some of it has to do with the FDA. They're so afraid we'll miss something that they want everything to be super sensitive. And when you don't balance sensitivity with specificity, and you don't look at that area under the curve you read about all the time, you end up with a lot of people becoming desensitized and ignoring. And you can imagine they have to be ignoring some of these alarms. So this is kind of the actions that they took based on some of the alerts. But can you imagine, that's 5,744 alarms a day, 410 alarms per bed. How is that manageable? Why do we let this go on? And then when we looked at, well, let's look at the BPAs for the entire team. Over 100,000 BPAs for the entire team in a month. Those are those best practice advisories. That's what they call them in EPIC. I don't know what they call them in Cerner. I don't remember. But these alerts, we love making those. In fact, we let doctors and sometimes nurses, but mostly doctors, they get to be epic builders. Fiona's an epic builder, but she's a smart epic builder. But they get to build these and they'll say, we need a BPA because people are forgetting to do this, so they create one more BPA. And guess when these BPAs happen? When you open up the chart because you're trying to do something for the patient. You're trying to document an assessment, you're trying to make an order because the patient's gagging on their breathing tube and you want to get them calmed down. You're the nurse, you're trying to give them medication, and then as soon as you open the chart, you get this BPA. And you're like, I got to do this first. And so what do? You ignore it. So most of them get quickly X'd out of. Sometimes they actually pick a reason, maybe 15,000 times they picked a reason. All the rest of the times they did not. So we need somebody else to manage that intelligence. Not the bedside providers who are trying to do something in the moment. They're caring for the patient physically. And so we can put virtual nurses. We can staff the virtual center or the virtual model with experts who have deeper knowledge and more experience to draw from. Their primary responsibility can be surveillance, if that's what you'd like to use them for. These remote centers have less distractions and interruptions. No one is walking up to them and going, hey, can you get my mom some ice chips? You know what I mean? They're not having that constant interruption. They can focus their attention. The expert nurses can rapidly adapt to using the tools because that's all they're doing. They're adapting to using these tools for surveillance, these continuous alerts. You've got a captive audience to teach them how to use these clinical decision support tools. And then the tools can be designed for continuous capture, analysis, and dissemination of information. And then the audio-video tools are obvious. And so one of the things I'm going to talk about real quick, and then I think both Cindy and Fiona are going to build on this topic, is sepsis surveillance. What is sepsis surveillance? Well, sepsis, I didn't put it in here, but it's one of the #1 killers, right, globally. It kills millions of patients a year. Sepsis surveillance is the purposeful, ongoing interpretation, synthesis, and analysis of individual patient population data to support clinical decision-making in sepsis identification and treatment. If you read my paper on looking at surveillance, it was like a kind of a primer to learn what surveillance was. I wrote it with Elizabeth Henneman from the Amherst campus of UMass. She's an expert in surveillance. I got a chance to write with her. It was exciting. But I took that same definition and I adapted it for sepsis surveillance. And then we said, what influences early identification and treatment of sepsis? Why is it such a big deal? Why is it so hard to do? And so we'll look at, from my dissertation study, one of the analysis I did, I have a minor in applied healthcare informatics with a focus on human factor science. So I'm always looking at this from how does the human interact with it? What are the distractions for the human? And when we think about it, there's a lot of distractions. So we have undiagnosed severe sepsis. That's what we called it when we were doing my dissertation. I know now they only call it sepsis because they have these new definitions. And then we have when we identify severe sepsis. So we have policy. In 2004, when I helped start the first remote sepsis screening program that I know of in the world, there was nobody saying you should do this other than Manny Rivers and Bryant Wynn and that team. So there was no public policies around sepsis. There was no SEP1, CMS, core measures. None of that was there. We didn't have any of that. We had social environments where we needed to have empowerment, leadership, teamwork, good communication, and group norms. We actually had areas that we were serving, other units that we were working with and partnering with that had never heard of severe sepsis and septic shock. They said, what is this thing that the EICU started doing called sepsis? It was very interesting. Even the physical environment, how hot or cold or how noisy it is, all of those can contribute and impact the person's ability, whoever's going to do this screening. Those physical environments can impact how successful they are. The nature of the work in general, is it complex? Are there competing tasks? Is there a lot of sensory stimuli going on, like all those 178,000 alarms, right, that are competing with your sensory level before you can get to the point of screening? There's physical requirements, cognitive requirements. What kinds of tools and resources? Are they screening on a paper flow sheet, right? Every patient? Well, when do I have time to get to that when I have a million other things to do? So what am I actually doing to screen? Do I have an alert, a BPA that's popping up in the middle of me wanting to do something for the patient that is immediate, and so I ignore it? All of those things. And then you get into your individual, how much is that person have situational awareness, problem-solving skills, competence, knowledge, motivation. All of those start to impact it. I didn't sleep well last night. My baby's sick. I was up all night with a sick baby, and now I'm working. All that's going to impact my ability to screen and have the best working memory to get to that. So this is complex, right? We make it sound so simple, and it's not. But a virtual nurse, oops, I went too far too fast. A virtual nurse is able to do that. We know that sepsis is difficult to identify, and we need time-sensitive therapies. In fact, if we delay giving antibiotics to someone in septic shock, every hour we delay an antibiotic administration, we increase the mortality by 7%. I see you nodding. You probably read the same study I did. So we know this, right? We know this is a problem. Alert fatigue in complex environments is a major technology hazard. So this has been, the last decade, this has been talked about or more. Expert nurses, again, use that high-level cognitive functioning so that they can actually process, filter, they have situational awareness, they can decode and decipher information at a much more rapid pace than a novice nurse or a nurse who's distracted, okay? And then, again, we already talked about this, they have that ability to really analyze those moment-by-moment changes in the patient. So if you decide to start a virtual nursing program, I'm almost done, and then you'll get to hear someone else talk at you. How many of you, now some of you came in late, so how many of you that didn't get to introduce yourself are starting virtual nursing programs or already have a virtual nursing program? You already have one, okay. Because several are starting or thinking about it. So if you're thinking about this, what would you measure for success? I'm gonna give you a few things. I'm not gonna give you my entire secret sauce. But I'm going to give you some so that you can listen to some of the work that these guys have already done in which they've measured it, and they're going to show you how they measured it. But you've got to start with the environment. If you drop your virtual nursing program into an environment that is not healthy, your nurses will struggle to be successful. We need healthy work environments on both sides of the camera. Free tool from AACN. It's a survey tool. You can send out an email link to it. You cannot see what the people who are participating, what their individual answers are. You see a rolled up of it, and it gives you great pointers on what to do with the information you get back. It's a beautiful report and a very helpful report. I would recommend that you evaluate it prior to implementation, and then you put a plan around improving the culture at the same time. And then I would do it again, if it were me, 6 to 12 months later, depending on how fast you're ramping up. And I would evaluate it again. And you're going to have countermeasures. You don't just measure it and do nothing about the broken environment, right? But the Healthy Work Environment Survey will help you. It will even give you ideas for countermeasures. Nurse turnover, so on a monthly basis, the number of voluntary separations from a unit divided by the number of unit employees, multiplied by 100 to get the percentage. So there's your calculator right there. You can put that in a spreadsheet, or if you've got some fancier tools, maybe you've got Tableau or something, you can build those in. And for each percentage decrease in nurse turnover, the organization saves an estimated more than $262,000. There's your message to your CFO, right? This is why we need to do this to your CNO. We can save this much money per turnover because turnover is expensive. It costs the organization a lot of money. You can always survey. I would say go find a validated instrument. Don't create your own. That's my researcher hat. When you create your own questions, they can be leading questions. Developing items for a validated questionnaire is a science in and of itself. But there's already ones that have been developed. Take those and slightly modify them. And then that way you're not accidentally leading people. Here are some other things you can do within the electronic health record. Create documentation tools that support extraction of discrete data elements. You don't want to be having to manually pull charts to find out your nurses did something. if you're in Epic or Cerner, create a nursing note that has discrete data elements for your virtual nurse, so you know how many times they wrote that note and what things they documented that they did based on whatever the problem is you're trying to solve and what you want to measure, right? Because now you can see the volume of activity. So it's just something to think about as you decide how you're going to do it. Look at how many times your virtual nurses co-manage complex patients, how many times they respond to clinical deterioration alerts, requests. That's built into most systems. If they've developed BPAs or other alerting deterioration, you should be able to see how often your nurses are participating in that so you can get the numbers. Keep the count of how many times patients and families request that. Many of the systems, if the patient pushes a button on there, it's going to tell you that the nurse joined that call. So most systems have the ability to collect those data and provide them back to you. If not, you might want a different system. But a number of admissions and discharges completed, and time to admission and discharge, right? If you had a discharge order, how long did it take to get the admission done, and compare that to pre and post data. Troubleshooting devices and equipment, how many times did the nurse document that they went in the room and mentored somebody through how to troubleshoot a problem with a device. And then all activities associated with nurse mentoring, number of nurses mentored, number of mentee activities per mentor. All right, and this is my contact information. You can find me on LinkedIn. That's always the best one, because if any time I retire, and I might someday, probably not for another 10 years, but then I might not be at Blue Cirrus, but I'll still be on LinkedIn. So next we're going to talk to have Cindy come up. Does anybody have any questions for me? I mean, we're going to do where we sit up here and you can fire away as many questions as you want, but anything that's like a burning question right now.
I have a question.
Mm-hmm.
When you were doing virtual nursing and you said you were in a 500-mile radius, were you in 2 different states?
No, we were all in California because California is so
I was gonna
big.
ask you
Yeah.
from state to state, policy-wise, did you have issues?
Wendy knows a lot about that, and so is Cindy. They've crossed, but you do have to make sure. I mean, I do consulting on this, so obviously you have to make sure your nurses are licensed in that state to practice. Compact licensures help, but it helps a lot, so that's nice. And then understanding the scope of practice within each state, which can differ. So in a nutshell, that's a couple of things you have to be wary of if you're crossing state lines. All right, ready? Okay. I'll give you this. Yeah, you can. It's more fun to walk around. It's easier. I hate standing in a podium.
All right, so I am going to talk about the,
I turned it off while I clicked it.
okay, sorry. So I am from, you can see all the different logos across the top there. We're now called Advocate Health. We're a brand new organization as of December 1st. So we are a combination of Atrium Health and Advocate Aurora Health. I am from the legacy Advocate Aurora Health side, so most of the things that I'm going to be talking about are related to the experience we've had there. But we became a gigantic organization with 42,000 nurses and 67 hospitals as of December, and that is all over the Midwest, and we call it the Midwest and the Southeast region now. So several states. Lots of different, we have now academic affiliation, which we have not had the benefit of having prior to that on the Advocate Aurora side. And, you know, I know probably this much about Atrium so far, but what I do know is that they have been going through lots of mergers all through COVID and very recently. So it's still a very new organization among Atrium, and now it's Advocate Health in combination. So lots of exciting things coming down the pipeline, I'm sure, and I'm sure there will be integrations and synergies that will come back in a year or two and be able to talk about. But for now, we're just all learning about each other. So on our Advocate Health, on the Advocate Aurora Health side, we do have a virtual care vision. And so we kind of have put it into 3 buckets. Across the top is obviously you want to use your people. You've got to have practice and workflows. You can't just plug a lovely little software in and hope that it works just fine because the vendor says it will, and they'll work closely with you, but it doesn't necessarily work without having that buy-in and having technology. And then mobility, like Teresa said, people can be working anywhere. We don't necessarily have to all be sitting in the same room anymore to provide telehealth. There's plenty of organizations that have their providers working from home, and they use different tools to communicate with each other. So I'm going to talk just a little bit about each of these things. So the tele-ICU, Teresa was the second, we were the third. We've been in existence since 2003. We'll be celebrating our 20-year anniversary in April. In our heyday, we had 749 beds that we managed across probably 7 states. Lots of different kinds of organizations, all the way from critical access hospitals to basically quaternary centers that did transplants and things like that. I'll talk a little bit in a few slides from now about why we're not 749 beds anymore, but there were all kinds of things that we were able to test out. We always used to say, and I still do, if you can put an E in front of it, you can do it remotely. So if e-pharmacy, e-dermatology, whatever you want to think about being able to do remotely, if you put the tools in place and you have the people and the stakeholders, you can make it happen. So we've talked about doing things like nutrition. Actually, during COVID, we had our dietitians in the EICU remotely checking in on patients in every ICU. It allowed them to consolidate their resources, look at those patients, provide nutritional recommendations, and keep patients and protect that PPE, right? Everybody was suffering from shortages of PPE, so the more we could do outside the room, the better off we were, and still able to provide patients. We do have endocrinology. We've provided coverage for endocrinologists at night. We have a big program in terms of supporting our ED ICU boarders in the ED. And then we've also looked at things unfortunately, we had a really great model for a telesepsis program that failed. And I can talk about the failure. Fiona will talk about the successes. One thing is everybody's suffering from being able to have hospitalists and intensivists now, right? Everybody's using locums. They're trying to recruit. So what's the next answer? What do you put in the bedside or in those positions? APCs, right? There's 1 million of them out there that all want to work nights, right? Everybody can hire them. And they're going to do it for the minimum salary that you can offer. So that became an issue. We could not fill our APC positions. It was a great model. It would have worked wonderfully. We had it set up where there were nurses and APCs that would be sitting literally right next to each other. Nurses could screen the patients. They could pass the sepsis patients on to the APCs to manage that early goal-directed therapy. That didn't work. So let's have hospitalists fill that in. They can moonlight. Hospitalists get short-staffed. What happens? They get pulled back to the bedside. You have no coverage. So we tried. We limped along with 2 APCs that we were able to fill the program with. They were excellent, but they were both part-time. One worked days, one worked nights. When you're trying to cover 24/7, you got 2 12-hour shifts by each a week. It just isn't very successful. The other thing you don't do is you don't try a new model and a new program together. So we went from trying to use the old Cerner model of 2 CIRS criteria plus abnormal labs to the predictive model of EPIC and identifying whether patients were developing sepsis. And trying to do that in conjunction with this whole new remote model of managing sepsis just didn't work very well. I still believe it's a great program. I think it would have been highly successful if we could have figured out a way to get that team there working together, and we tried to incorporate hospitalists from the bedside. What they hated was that the way the EPIC model works is if the deterioration score continues to be over a certain threshold and labs come back abnormal, they want you to drop labs again. And so these patients were getting stuck multiple times in a day because it's firing every 4 or 8 hours. So anyway, lots about why it doesn't work, and Fiona will tell you more, and I'll move on. We do have a patient command center. This is not one of my reporting areas, so I'm not an expert on it, but it's a great centralized way to do patient bed assignments, transfers, transports. They're looking at doing discharges. They actually have people from EVS and an ambulance company sitting in the center so that they can make arrangements to dispatch to get patients transferred from one site to another. It was really around keeping patients in our own system, stopping the leakage. It's a really wonderful program in terms of getting our patients, the logistics of patient movement handled all in a central way. And then we have virtual hospitalists. We certainly have a large behavioral health program. I don't think anybody has enough behavioral health providers. Is everybody doing virtual behavioral health? Yeah. You find very few people anymore that have enough providers themselves. We're on the verge of talking about virtual home care and supporting that with virtual nurses. And then virtual SNFs. That's another area I always believe could benefit significantly by having a virtual provider to round on those patients and prevent those admissions back to the hospital. In terms of remote monitoring, you may not think of telemetry as remote monitoring or being a virtual nurse role, but it is, at least in our system. We do have a centralized telemetry center, which actually is co-located in the same building floor as our tele-ICU and our patient command center. So we're all, it's one big virtual area, and it works very well in terms of a little bit of sharing resources and having that ability to have the, a really difficult patient that, do we really need to put them at the tertiary care site, or could they go to a next level of care, and having that ability to have someone there to kind of troubleshoot right in the moment. And then our baby program, January 9th, started virtual nursing. I'm going to talk a little bit about that. And as I said, we're now looking at doing some home health. The other thing we do is virtual patient advocate, we call it. You may call it telesitting. That's all done with text, so we don't have nurses in that program other than the manager is a nurse, and quite effectively is able to liaise with the bedsides when we have challenges. I know no one can imagine that when a tech calls a nurse and suggests that something's happening with their patient, they don't always receive it well. And so it's helpful to be able to have a nurse call and talk to another nurse. So how do we use the tele-ICU to support nursing? Teresa has spent a lot of time talking about how many new nurses you have at the bedside. They all go to the night shift now, and they, again, maybe 1 year experience as their preceptors or mentors available to them. And this goes back for us all the way to 2012. We had a particular ICU come to us and say, we are having a terrible time retaining nurses. They're turning over in less than a year like crazy. Is there anything you can do to help us? So we put together, we had always had a mentor program, but it was not as formalized as we ended up making it. And I think putting the formal infrastructure in place is really what has helped. We've now had over almost 500 nurses go through it. We've always got people in the pipeline, and we've always got people, that have been recently enrolled. But what we did was develop a post-orientation program that's really meant to provide support and ongoing feedback. So at the beginning of their shift, the nurse calls their mentor from the bedside and says, here's my patient assignment, this is what I'm thinking about the patient. The experienced ICU nurse on the other end in the tele-ICU is able to ask some pointed questions about what they might be thinking about, give them a little bit of advice. They're welcome to call anytime during their shift that they just get a feeling something isn't going on right. And then at the end of the shift, they kind of debrief. This is what I saw you do really well. When the patient started to have issues and you started titrating the meds, that was great. When the blood gas came back abnormal, the fact that you called me to discuss it before you called the doctor was a positive thing. So they're able to get that kind of feedback in real time. They are asked to do a self-assessment prior to starting the program, and there is a formal orientation with the ops director of the tele-ICU with that nurse to kind of let them know how the tele-ICU works, what they can expect, what their expectations are. We actually have them sign an agreement so that we engage them in feeling that this is an important part of their experience. And again, it's based on moving from that novice to, novice expert, if that's a term, nurse, as they get through the end of their orientation for the next 30, 60, or 90 days. So it really is driven by the needs of that nurse and then their educator or manager, whoever is the liaison to our director, to decide how long that program exists for them or continues for them. And we've gotten really positive feedback. This particular unit that approached us in 2012, by 1 year later, they had had none of their nurses leave. So it really is a recruitment and retention tool, because it provides that additional support. You know, now when you have people working short-staffed and more patients than they're used to having, even though I'm supposed to be Teresa's mentor, I'm going to be busy with my patients in my ICU. So if you call me and ask me you come to me to ask a question, I'll try, but I may or may not be as attentive as the virtual nurse on the other side of the camera is able to be. So that has been something that we've adopted and adapted. It used to be an in-person on-site visit, which was great to have those nurses come and see what the tele-ICU looked like. As you can imagine, as we provide services farther and farther away, asking them to drive to our central location becomes more challenging, and then COVID prevented anybody from going anywhere. But this is, I think I've kind of talked about this, but what we have learned is that we had a lot of expectations of our own nurses. Now, a lot of these nurses, again, a minimum 5 years experience in the ICU, many of them more like 15, 20 years. But just because you're a good bedside nurse doesn't mean you know how to talk to other people. So really helping them learn to mentor their mentees and be a good preceptor. We had to bring in our organizational development partners to provide a little education for them on what it means to have good communication skills, use the principles of adult learning as they're talking to their mentees, and foster that critical thinking that just takes time to develop, and really helping them learn how to do that. We think each ERN can handle about 2 nurses in 2 different units on any given shift, so you can't overwhelm your own tele-ICU nurses with doing this, which means that you have to adjust sometimes schedules and assignments so that when this particular assignment is really busy, the units, the tele-ICU's assignment, they can handle multiple ICUs at a time. They can handle 3 to 5 ICUs depending on the size of the ICU, the acuity and the amount of support we provide to them. They may have to have a little bit of an adjustment because they're going to be working with 2 nurses at the bedside tonight, and it's going to be a little bit busier for them. We do have lots of people ask to be able to use it, so we have at different times had to prioritize how we put people into it. We do try to say new to ICU. Now, whether that means you're a new grad or you're transferring from the med-surg floor into the ICU and you don't really have that critical care experience, that's kind of the candidates we look for. And then another lesson learned is don't expect the mentee to provide you with their work schedule so that you can match them to their mentor. It just doesn't happen. They get very busy. The other thing we learned is that our mentor has to call the bedside nurse and say, hey, let's talk about what's going on. Sometimes at the end of the shift especially, they just get busy and forget. So you overcome those things. You get access to the nurse's schedule so that you don't have to depend on them to provide it to you, and you match them with people. Sometimes they have 2 mentors because you can't always make that a one-to-one match in terms of schedule. I talked again about the CTC. This is a new space for us. We've only been here about 2 years. This is a day in the life, right? They're really busy. They're monitoring 48 patients. Often these techs are right out of, maybe they worked at Taco Bell at their last job, or they have absolutely no healthcare experience whatsoever. The best situation you can get is something like an EMT or a paramedic who's interested in becoming a tech. That just doesn't happen. So you, again, learn to adapt your training and the skills that you teach them to what their level. We really only require a high school diploma. That's the requirement to become a tech. So what do nurses do? Well, we're monitoring now 9 hospitals within the state of Illinois at about 1,300 patients. We run about 75% capacity, so on any given day, we're well over 900 patients that we're looking at. So that demands that you have standard workflows. You can't just have everybody do whatever every hospital site wants you to do, and then it'll just be great for them, but no one will ever be able to keep up with what's going on. So we do utilize our EMR to do secure chat and be able to reconcile that the patient we think we're monitoring in this room is the actual patient. And the key, our secret sauce, and I don't have a copy of it in here, but we have created an escalation algorithm that really allows our techs in our CTC to go all the way to the point of calling a code blue if they need to, or a rapid response. And it's very well specified in terms of when you get it to a lethal arrhythmia, there's a whole escalation. I'm going to call the nurse first, I'm going to call the charge, I'm going to call the house supervisor, but I'm going to make all this happen within 5 minutes, and if it doesn't, I'm calling the code while my partner is calling the bedside to let them know I'm calling the code. And that has worked very well for us. As you can imagine, the bedside doesn't always love it when they haven't communicated to us that, you know, something's going on with the patient, and that's why they look like they're having a lethal arrhythmia, and here comes the code team. But we always, you know, default to we'd rather have a patient alive than wish we had called the code. We have about 160 monitor techs. We have a 1:48 ratio. If anybody has some secret formula for the right number of patients to techs, I would love to know it, because we struggle with that sometimes. That's a lot of patients when you think about having, you know, at least probably 2 waveforms, a heart rhythm and an SpO2 monitor for every patient. You're now talking about double 48, 96 rhythm strips to monitor for a tech at any given time is really a lot. And you talk about noise. It's so noisy from when walking to the tele-ICU into the CTC. It's like you've gone into 2 different worlds. But what does that have to do with nurses and virtual care? We have a charge tech, but we also have arrhythmia nurses. So every shift has a nurse on site that is a resource to our techs. And they are critical care trained, so they're critical care experts. They're very well versed in arrhythmia and rhythm strip interpretation. They become a resource for both the bedside nurses, because as you can imagine, even though we want all nurses who take care of telemetry patients to be competent in telemetry and rhythm strip interpretation, they're not all experts at it. They're new nurses. They're still learning everything. So they have a resource that they can call and ask for help to look at it, because we have a duplication of what they're seeing at their central station. We've got a surveillance and an overview, so we see exactly the same thing. We can help them out with that, in addition to the patient having the rhythm right on their box, the particular kind we use. They help identify patients with rhythm abnormalities, and then they're able to make sure that if they're on cardiac medications, that those medications are titrated appropriately to the rhythm that they're seeing, and intervene if that isn't true. They also are key in providing education to our techs and really developing them and recognizing those arrhythmias. Real time, I can see something, I can walk right over to Fiona who's monitoring that patient and say, let's take a closer look at this. This might be something you want to be alerting the bedside about. And then again, acting as the liaison. Our techs don't always get warm welcomes from the bedside nurses when they're calling to tell them that their patient's having an arrhythmia and they disagree with it. We do feel that real-time education really helps identify our opportunities for improvement. We work closely with the bedside when there are safety events. We have a 24/7 on-site and easily accessible by a phone. They can intervene with the techs when they're doing their rounding, and they're on-site experts, so they're often asked to participate in system-level committees to help develop the education and different protocols. What does all this mean? This over here is our data on our RRTs by month. This is the month across here. You can see here there's 4 sites that have been with us the longest, and then this is a rolling 12-month. Bottom line, what you want to see is that we're seeing the number of codes that have to be called on a monthly basis. If nothing remained very stable, it decreased a little bit. And part of that is because we know our escalation algorithm is working. So the nurses are helping the techs understand when a patient's having a lethal arrhythmia, and they're making sure that patient gets a code called. An RRT, and then this is the code. And again, we've seen way fewer codes being called now, because what does that mean? We're intervening earlier, and we're having success in keeping these patients from getting to that lethal arrhythmia. We're, getting the cardiologist call, we're getting them to the cath lab, whatever needs to be done. So we do feel like having that nurse on site helps. So this would be what our tele-ICU would look like today if we didn't start our virtual nurse program. Pretty empty, because we'd have a lot of extra space. What does that mean? In late 2022, as we continued to have staffing challenges like everybody, we had a lot of travel nurses, we had a lot of agency nursing. we really looked to identify opportunities to support our med-surg nurses at the bedside because they are working short-staffed. They have way more bigger patient to nurse ratios than they'd ever had. They're working with nurses who are unfamiliar with the system, and it was just a challenge to retain them. We're losing them left and right to become traveling nurses and go. We developed our own internal agency to try to create a travel nurse contract to keep our own nurses. You know, everybody did all these things, I'm sure. And we also simultaneously made a decision to significantly decrease our tele-ICU coverage. Again, from a financial perspective, having 24/7 intensivists at the bedside and having the second layer, which we always thought of as a safety net of the tele-ICU, was no longer financially sustainable. So any of our hospital sites that had 24/7 intensivist coverage, we removed the tele-ICU from. We're still in 13 of our hospitals across Illinois and Wisconsin, but that impacted us significantly in terms of staffing. That left us with a redeployment of 20 seasoned tele-ICU nurses. You don't want to lose nurses that have 20 and 30 years of ICU experience because you've restructured your program. And so because we really wanted to keep those nurses and we knew we were starting this virtual nurse program, we stood this program up in about 6 weeks' time. There were multiple people working together. We really thought about what can we do to retain these nurses and yet start this program where we know we have staffing issues on the med-surg side, and we created the virtual nurse program. And 12 of our nurses that would have been otherwise redeployed elsewhere, or actually anybody who didn't go to the virtual nurse decided to go back to the bedside. Some left the system, some stayed. But we were able to start our program on January 9th. What did we have to do to make that happen? We had to be budget neutral, so we went to our pilot sites, which were piloting in 5 sites. They had to give up vacant FTEs. Every one of them had plenty. They didn't like the idea of giving up their FTEs because then you give it up, you never get it back, right? Everybody's done budgets. But they recognized that it was for a reason to support their own sites and that these positions had been vacant for quite some time. That's typically what they did. Whatever positions they had that had been vacant the longest were the ones they donated to the program. We had to be technology neutral. We had 150 wireless carts from when we had stood up 400 additional ICU beds at the height of COVID. That I won't say they were sitting gathering dust by any means, but they weren't being utilized the way that they had originally been intended to. So it was a great opportunity to reduce those carts. They may or may not be called Caregility. And we were able to get those reconfigured in a way that allowed us to use these in our med-surg units. We initially focused on just tasks, that admission discharge. Again, as Teresa said, I can't do every part of the admission and discharge process because some parts require that I can look at what your belongings are and see what you're going to have at the bedside, but there's a whole bunch of it that I can. We will be moving in the very near future to the transfer, monitoring, care coordination, and mentoring of again, there's plenty of new nurses on the floor as well. And we had this extra space available. So geographically, we've got 2 departments sitting right next to each other. They've all been co-workers for years and years, and it works out great for us to be able to have everybody right there. Sorry. So again, we right now are focused on completing the admission process within 4 hours and completing the discharge process. And what are our metrics? We're looking to see that we increase the number of patients that are discharged by noon, with a target of no later than 2 p.m. That's the bottleneck all the time, right? We have plenty of patients waiting to be admitted in our EDs, but we have no beds to put them in. So if we can get these patients discharged, then we can get that bottleneck out of the ED. And so one of the things, well, I'll show you our workflow. And then in the future, these are the things, there's so much more we're able to do with this. A lot of them Teresa talked about already. Looking for deterioration. We had a great catch of a nurse doing a discharge and noticed the patient had blood all over their new knee dressing and asked, I see this patient looks like they're still on anticoagulants. Is that really what the physician wants as this patient gets discharged home? So just having, again, that critical thinking and that ability to assess the patient across the camera has really made a difference for some of our patients. So I'm going to click through this until we get it. This is our admission workflow when a patient is in the hospital already. So they've been moved from the ED up to a patient floor, and now we're admitting them. So the primary nurse will screen to assess you. Can you imagine, what are some of the criteria you would imagine do not make a patient a good candidate to be admitted virtually? You think every patient that gets admitted to the hospital could be admitted remotely? What did you say? What'd you say? Hearing. They can't hear. You're right. Exactly. They may not speak English as their primary language, and they don't have a family member there to help them. They may be confused. Those are probably the major criteria that we learned very quickly, that has to all be screened before we put a patient on the camera to try to help them. So the nurse does the screening, and then they call us and let us know. They use secure chat. I have a patient in room 432, whatever, here's their name, here's information. And then we go through this whole process. I won't read this to you, but basically then our nurse can start to perform the part of the admission. Once they get that completed, they secure chat back to the bedside nurse to say, here's everything I did, here's what I noticed when I was talking to them. They seem food insecure, or they may not understand their medication, or they think they're here for this, but the chart says they're here for that, anything that they find. And then we are keeping right now an internal log, and then the nurse. What do you think the biggest challenge with this program, this workflow is? When you have bedside nurses who are working with remote nurses over a camera, what do you think the biggest challenge to the success of this workflow is? Absolutely. I can't tell you how many times we had carts offline because we cannot get the nurses to plug the carts in, and the batteries go dead, and we remind them as we're closing the program down for the night, please move it to the storage place and plug it in so it's fully charged for tomorrow, and they go, okay, and they go off to their next patient. We try to admit the patient the next morning, and cart's dead, offline. And then we're putting an HIT health information, a service desk ticket in. Hey, can you go check on that? The cart's offline, they go down, reset, and it's ready to go. And they get so frustrated with us. So that has been the biggest challenge for us, quite honestly. It wasn't necessarily getting them to buy into the process, it was getting them to plug a cart in. Different workflow when we're doing it in the ED, and I can tell you our most successful site is an ED. And the difference is that it's really us that, and when I say us, the virtual nurse that starts the program. So they look at all the patients that these two ED, we're covering two EDs. They each have a designated area. One has the purple zone, and one, the patient can be anywhere in the ED. But we look through the ED board and see which patients look like they have an order to admit. That's another thing we learned fairly quickly was don't wait until they're ready, they have an admission order, a bed placed. Wait, as soon as they have an order to admit, they're going to be staying, start that process and get them admitted. Because if you're waiting for the bed to be assigned, it takes a lot longer. It's a much smaller pool of patients, and now you apply those criteria of they don't speak English, or they can't hear you, or they're confused, you have a much smaller pool of patients that you're able to. Having someone on site that's your champion to say, these are the 5 patients I want you to start with, really, I can't say enough about how much more successful you are when you've got a champion on site at the site you're providing services for. So really, the same process happens, it's just who initiates it. For us, on the ED side, it's the tele-ICU nurse. On the bedside side, it's the bedside nurse. So a little bit of data. This is really difficult to see, but it's just week over week from the time we started, how many patients did we admit at each of our 5 hospital sites, and in total, as of this week here, of 220 to 226, 872 patients. Today the data came out, we're up to almost 1,200 patients that have been admitted. Much smaller volume that get discharged. There's really only a couple sites that have us doing discharges, 3 of the 5 sites, because we don't discharge from the ED. So the 3 that are on the inpatient side is up to 235. And we're doing kind of a side-by-side comparison with that. And Teresa talked about centralized versus decentralized. we have a centralized program here. These are the sites. These are the things we're looking at in terms of metrics and things we're learning. And then there's three sites that decided they wanted to do it locally. So they have an admission discharge nurse, and they're actually having that nurse go into the patient room, whether it's in the ED or the med-surg floor, and admitting that patient face to face. But that's their sole responsibility, is to do the admission discharge. So this is kind of their criteria here, their volumes. Right now we're having a real challenge getting data out of Epic. As much as we have a wonderful dashboard of things we want to measure, getting that out of the EMR is not as easy. But anecdotally, our nurses are saying it's awesome, an awesome way for admissions and discharge, but weird in a really good way. And the program has been a gift from God. I don't know about that, but it is something that they've liked. Patients really like it because they get that one-to-one attention. They're not getting somebody coming up to the nurse and saying, "Can you get my mom the ice chips?" They've got that nurse and we happen to have, very luckily, 2 people that have case management experience that are part of our virtual nurse team. And again, that ability to talk and really glean from patients what their needs are has been helpful. Now, I've talked enough and someone else will talk at you, but any questions that I can answer?
Question for you. On the last slide, you said something about patient engagement. So you talked about what the nurses think, but what are the patients and the families? How do they feel about it?
Very early, but very positive feedback. We started meeting daily, then weekly. We're at every 2 weeks now, and every part of every meeting discussion is what's the feedback you're getting. Again, what we're looking for ultimately over the long term is on the very specific questions about, did you feel like you were well educated at the time of your discharge? And then there were a couple other questions we've selected. We hope to see that change for the patient on the units that we're covering. But anecdotally, they love that attention. They love the fact that I can see you because it's a two-way camera and you're paying attention only to me. You're not answering your phone. You're not having somebody come in and talk to you. So it's been really positive. Both patients and families.
I was going to ask about your text. What's kind of like your screening process for determining who is a good fit for that type of position? Because we have something a little bit similar. We have text, but we have a really hard time figuring out, like, do you really know technology, or
Yeah.
am I starting baseline?
It's a challenge. I can tell you when we started our CTC, we had to hire about 200 techs in about 6 months. And I'll be honest, at that point, we were hiring warm bodies. If you showed any interest, we were happy to have you. Yeah. But we did do a lot. The manager there, highly experienced tele nurse, did a day in the life of, because people don't really understand what it means to sit and look at squiggly lines for 12 hours straight. Yeah. So we try to do a little video that we actually put on some of the social media platforms to give them some sense of what it would be like. And then, there's obviously a lot of training that goes into learning to read rhythm strips, and sometimes you lose people there because they figure out this isn't what I really thought it was, or I don't think I can do it. And then your best recruiters are your techs, so they start bringing in people that they know. There's no magic bullet, though. I wish there were. Stand behind you?
Yeah.
Okay.
Oh, I'm going backwards. That's not gonna work. Can you hear me if I stand here? I'm pretty loud normally to begin with, so I don't. Can you hear me? Is that better? Okay, good. All right. So, my name is Fiona Winterbottom, and I'm a clinical nurse specialist. I spend 50% of my time as a provider in the intensive care unit for our pulmonary critical care team. So I round and take care of patients, write notes, do all those clinical things. And then for the other 50% of my time, I do a lot of other things, including quality improvement. And as Teresa and these guys were saying, I am an Epic physician builder. That was a new skill I got in the last 6 months, largely because I like to fix things. So I go to work and find all the problems, and then I try and fix them. And sometimes they don't fix them fast enough for me, so I fix them myself. So that's kind of how that works. The other things that I do, I am also an advanced practice certified hospice and palliative care nurse, and that's partly, again, because of my critical care work. My chairman of my department started our palliative care program, started our rapid response program, started our code team, started our telemedicine EICU program, and hence I am also a person who does all of those things, which brings me here today to share with you one of our programs that we're currently working on, which is our sepsis program. So one of the things that we usually get asked is, how do you get started? Well, you usually get started because if you're like me, I am like a magnet for people to bring me their problems, because once they know you fix stuff, you become the fixer of all things. So I can literally sit there when I'm on a day at work. In fact, it happened to me last week, and I got like 9 projects in a 12-hour shift because people come find you. So what my role has become, though, is to help those people fix their own problems. Because I can fix a problem, but I'd much rather you fix the problem with me, and I'll help you fix it. So that's where I usually start, and that's where that's, like I say, I'm going to talk about this sepsis project, but that's generally how we have to identify the problem. And a lot of times what does happen is people bring you a problem, but that's not really the problem. And so we all talk about it. We actually talked about it at dinner, is sometimes you look like you're a non-believer or a disruptor because you ask the 5 whys. Well, when you ask a why, some people don't like you to ask the why, but I ask a lot of whys, and so sometimes it's not always perceived in the way that it is meant, which is to try and really get to the bottom of what the problem is. Because otherwise you end up solving the wrong problems. And so people go, well, why didn't your project work? Well, because we didn't solve the right problem. So, and I'll show you that as an exemplar in this talk. So then the other thing is to brainstorm the solutions, because even though I think I'm really smart and I have lots of ideas, I'm not always the smartest person in the room. So getting other people to participate and bring their ideas is super helpful to get us to where we need to go. Make sure we're looking at evidence, as Teresa gave you a list of studies. Some of the things I'm going to talk about are in there. Make sure that you have evidence to support what you're doing, because otherwise you're going to struggle. So what we've tried to do is we've tried to use our EMR as our standardization. We try and make sure that all the evidence supports the workflows that we put in place, and then use our virtual nurse program, our EICU program, to make sure that then when we are doing things, it's actually the right things that are getting done, and all the adherence follows those pathways. Make sure you're aligning with strategic priorities, because if you're not, your project won't get very far. Make sure you're gathering supporters along the way. So I am very collaborative. I reach out to 1 billion people, and then people say, well, why did you tell that person about this project? I'm like, because that's your key stakeholder. You need to get them involved. Otherwise, what's going to happen is they're not going to agree with you at the end, and then your project will fail. I don't like my projects to fail. And then make sure you're continuously evaluating the program. This is basic, like, lean methodology. And so the other thing is, work with what you have. So we all want to be perfect. We all want to have perfect projects, but we don't all have a perfect world where we can get every resource we want, when we want it, how we want it, and in the time we want it. So I'll show you in this presentation what we did with the things that we did have and how we made those work, and then we can gradually scale them. So these are kind of the things that we used in our project here that I'm going to talk about. So as Teresa said, sepsis is a big problem. I'm sure it's #1 at your organizations, just like it's #1 mortality in our organization. And so it's huge costs. It's at the top of everybody's hit list when we're looking at mortality. And so how do we solve for that? So in our organization, we decided that we were going to use our EMR. I'll disclose that it's Epic now, because you'll already see that when you work through this. And we used a predictive model, or a predictive algorithm. We actually did our algorithm before Epic did their algorithm, but it's very similar. So if you're using it or any other algorithm, the principles are the same. So our organization decided that they were going to implement a predictive model for sepsis. which is great. We spent a lot of time working on it. We spent a lot of time building analytics for it. But you also have to have it interact with people, and that's when you really learn if it works or if it doesn't work. So it's great to have a tool, but as I tell people all the time, it's like having a treadmill. You will not get slimmer or get healthier if it just acts as a clothes horse and you just hang clothes on it. You actually have to figure out how to use it. And so that's kind of what we started. We put this predictive algorithm in place, and it had best practice alerts, and it had all these fancy clinical decision support tools and everything. It was fantastic. It's a great tool. But when we went to implement it, it was in Delta wave of COVID. So we were now on 4th time we've built about 5 new ICUs in 2 years. And then subsequent to that, we had Hurricane Ida, which wiped out most of Louisiana, which is where I live. So we didn't really have good uptake and adoption in this tool. So I happened to be sitting in our EICU, and I was actually trying to help our team because we had so many patients on 16 floors that were deteriorating that I just decided I was going to sit in our EICU bunker because I could move from patient to patient really quickly. So I was the virtual provider, and I could help them identify which patient they needed to go to. I could help them write notes. I could help make sure the patients were moved to the right places. And so while I was sitting there in between times, I realized that our sepsis screening adoption was not super great, but I could also screen patients while I was there. So I was like, oh, this is great. Let's see how we can utilize this. So then I went back to my real job at the bedside, and I had one of our unit managers who had several staff that were on restricted duty. And she said, oh, can you find some work? I can always find people a job. So I was like, yeah, I've got a job for them. Do they want to do the sepsis screening? So we actually had ICU nurses that I wasn't taking away from the bedside because they weren't able to work at the bedside, to actually do sepsis screening like I had been doing, just kind of as a test. So that turned out to be really a very good model. So we tested it for about 3 months, and then we were scaling. We had started our sepsis screening in one hospital. We scaled it to 2 more hospitals. So not everybody interacted the same way with the sepsis screening. So we did have one hospital that kind of worked with us and wanted to adopt this model. It was a community hospital, actually. So that's kind of where the sepsis screening took off. And I'll show you a little bit more about that. And then, so that's kind of where we went. Some people adopted, some people didn't adopt. And so we got to use the clinical decision support tools. We got to figure out how they interacted. We got to develop the medical record further and really figure out what worked and what didn't work. And so part of this is don't try and be perfect. There's no need to be perfect at the beginning. You are going to grow and you are going to evolve, and that's okay. And what you start with will not be what you end up with. And that's part of what you need to know going in, because that will make it more successful on the back end. So that's kind of the summary, and then I'll show you a little bit more detail. So the automated screening, for those of you who don't know how the sepsis model works, is that it literally takes all the patients that you are serving in your hospital and kind of filters them into who are at a certain level of risk. So are they very high risk, and then we put at risk versus put no risk, because that seems like everybody could be at risk. And it filters them from maybe 500 patients to 50, and then of those 50, what do you need to do with those 50? Maybe it's 5. So just like these ladies have talked about, how do you reduce burden of work? How do you work smarter and not harder? That's literally what we tried to do. So many organizations, and I'm sure you guys did this too, we had nurses screening twice a day on paper for sepsis. Okay, nobody needs to use paper in this day and age, first of all. Second of all, nurses have better things to do. And then the times that they were screening, people were just checking boxes. It wasn't very effective, and it certainly wasn't easy to capture. So we used this automated screening tool. We created workflows. The initial workflow, that was kind of how we set the screening up, was that you would have, the patient was at risk of sepsis, the bedside nurse would get a best practice alert. They would screen the patient. If they had a positive screen, they would order a lactate. So that didn't really work well because the bedside nurse had a get out of jail free, chart review, whatever you can do to get out of it, because we were alerting people when they weren't ready to receive alerts, nor was it took them off the task that they were already trying to accomplish, like Teresa was saying. So we were getting all this alert fatigue because we were just trying to move through the chart because you wanted to move on. So we had put a second level of surveillance in, which we called E-Rapid Response. We've called it different things at different hospitals because every hospital is every hospital. Every culture is every culture. You cannot put your culture in somebody else's hospital. You cannot take somebody else's model and put it directly into somebody else's hospital. It just doesn't work. They have to be ready to receive it, and you have to have the right change management strategies to go with it. Otherwise, it will fail even if it works in somebody else's unit. So we called it E-Rapid Response partly because at this particular hospital, we had taken our model of rapid response during COVID, and they had a nurse that was assigned to be the rapid response nurse on site. They worked with what we called our E-Rapid Response nurse to help treat, once we'd surveilled the patient, the high-risk sepsis patients. We built a list in our EMR that put all of the patients in just a big patient kind of list, census. And that was different to the best practice alerts in that it wasn't hitting you in the middle of a patient. It was a list that could be seen by anybody in the organization. It didn't have to be it could be PI, it could be a provider, it could be a nurse, it could be anybody who happened to want to look at the list, which actually was what it was designed for at the beginning, was for a quality improvement. So we had them patrol the list for patients. When we first started the list, it was just a high risk, very high risk, at risk, and we'd have different colors. So you're essentially red, yellow, or green in the hospital, similar to many others. If you got a positive screen, we didn't automatically expect the nurse to order the lactate. We had them communicate with the team. And the difference between the BPA and the screening list is that with the BPA, we have suppression logic. So if you're on an antibiotic, it is not going to alert, which is fine, except for sometimes patients are on antibiotics and they're still deteriorating, which is where the second level of we had to have little bit more cognitive adjudication of the list than we did of the screen. The other thing that happened to us, and that may have happened to you all, when we decided to put this in place, we had Delta wave, we had a hurricane, and then we had a shortage of lab tubes. I don't know if you all have that too. So we had no tubes to actually draw lactate, so it was great. So again, anticipating all of these things, but you just make it work. So we had the team work with the bedside, and we used our secure chat mechanism also for that. And the other thing that we did was we put in place once you'd done the screen, we had a way to flip it into the chart, because as a provider, when you're reading the chart, you're not looking at nursing work, like you're not looking at nursing flow sheets. That's not how providers work. So we had it flip into like a clinical note, so that when they were going through their charting or they were doing their patient notes for the day, it would be a reminder, particularly for the patients that were already on antibiotics. Did we need to broaden them? Did we need to think differently about their treatment plan? And instead of hitting them when it didn't make sense in their workflow, we hit them when it did make sense in their workflow. And so that seemed to help. Many of our providers don't love multiple secure chats. I'm sure yours are the same. And so we tried to limit that as much as possible, and that was one strategy for that. During all of this, we're further developing our EMR to make sure that it works for all the interaction that was needed. From the staffing model, we actually ended up working with our HR team to make sure that we had a process for anybody who was a restricted duty nurse, that there was a process that involved our insurance companies, things like that, for them to be able to work with us if they wanted to, because they can be put on light duty and then they have a selection process of jobs that they can be offered, etc. So we ended up working with the HR teams to define that further, so now it's in place for other people. So this is a picture of our first kind of pioneers, I call them. They were two nurses that were off for a while, so they had some extended light duty. And just like Cindy showed, these would have been vacant. Like these two setups were sitting vacant before we took them over. So as she said also, budget neutral. We didn't hire one extra person. We did not get one more piece of equipment. Everything was done budget neutral. And so from this, our outcomes from this one were initially, this was one community campus. We started on the med-surg floors, med-surg tele floors. Then we went to the ED and did ED holding, or ED admitted patients. And as you can see from this, the numbers at the bottom in the blue line, are anywhere from, I don't know, about 6 to about 29 is the highest. That is the screening volume of the patients 24/7 at that site. That can be doctors, nurses, whoever opens the chart and screens 24 hours a day. If you look at the numbers on the yellow line, they're in the 250s-ish. That is the number of screens that were done by our virtual nurses 6 hours a day. So it's very clear that you can screen more people if you have a strategy where you have focus. And so our CMIO likes to say it's like panning for gold, trying to find the sepsis patients. You have to screen a lot to find the true gold. And so this is a strategy that makes that workable. It also means that the nurses at the bedside are not constantly getting hit with alerts. Because remember, the sepsis alerts aren't the only alerts that they're getting. They're getting multiple alerts for multiple things. So this allowed them to kind of not get as many of those alerts or have somebody helping them. This is a Tableau dashboard that was created kind of before we started, or before we started the program. It's been further developed since, but we specifically asked for this to be where you could see the difference between the virtual nurses and the bedside team. And there's filters, kind of, if you can see at the top, where I can add people if we add new nurses, if other people are screening at different facilities. So it's very interactive, and then the total numbers are at the top. So we have this for all of our campuses, so we can cut and slice and know where they are. So that's one thing to mention, is that we had a very good collaborative team. We had weekly meetings to make sure that this would be, I say weekly meetings, we had multiple meetings on each week for different things. So the clinical team, the provider teams, the analytics team, there was a lot of sepsis meetings. And so that's, the feedback was that we very quickly changed dashboards, et cetera, for that. From this particular hospital, I can show you outcomes for our sepsis mortality, and because we had done it for the whole year of 2022. And so the red is the observed, and the blue is the expected, and you can see that we were way above expected at the beginning of January, and by November we were down below expected with our sepsis mortality. So just an example of, ours was not the only program, there were multiple different efforts, but we learned a lot from this. It wasn't just the virtual part, but we also learned a lot about documentation, what was being coded, what was not being coded. how we could pull the patients out, because if you look at risk-adjusted mortality, you only need 1 or 2 patients to move it. We could look at different CMS measures. I'll show you another dashboard, I think, in a minute that shows how we looked at that too. But just to give you an example of, it's hard to get mortality. You know, that's a nice outcome, but it takes you several months to get there. So this is just an example of one of the measures that you can look at. So then we kept going and looked for more problems. And so we had 2 units that were in our academic medical center. So now we've moved from our community facility to our academic medical center. And this is very busy, but what we wanted to show was, I talked about the BPA that we had, or the best practice alert. What we found as we worked through all these measures was that people who were at the bedside were not actually fully answering the questions in the best practice alert. So if you didn't fully answer it and you escaped out of it, it just kept pinging. So it just kept going and going and going, and it would just hit another person and hit another person. So the alert fatigue was real. It kept happening. And so what we did was we took 2 units. One was virtually monitored, did have cameras. The other one did not. So it was a couple of proof of concepts. One was, could we do it in this environment? The unit that did have cameras had 100% agency, 100%, including the charge nurses. That's a 34-bedded step-down unit. So that one actually probably did the best and had the best outcomes from this program. But what we learned was a few things. We learned that if the virtual nurses would actually complete the screen, the number of alerts went down overall. And so that's what this step is designed to show you from month to month, is that we started the program December 11th, and the subsequent months we went down on the number of alerts total because we answered them correctly to begin with. So you can see how that can impact overall, because it doesn't just impact the nurses, it impacts the providers, it impacts everybody because they're not constantly getting these alerts. So again, dashboard for this, cut and sliced, love our analysts. And so we were able to kind of use this and then think about kind of where we went next. So our results from this were that we had 100% improvement in what we called our action to screen or alert to action ratios, because we were able to actually answer them. We looked at our number of screens, the average number of screens that we did for that. And remember, this is just one, this is 2 units actually. We could look at those and see what that was. So we obviously increased it because we weren't doing it before. We looked at screens not complete, which obviously the other piece is the screens that were complete. And then the number of monthly alerts that happened. And then at the bottom, I wanted to demonstrate the difference between the non-pilot units because all their numbers went up. And so bearing in mind, I showed you what time frame that was. It's our busiest season. January through March is our busiest time in the hospital, probably most people's hospitals. But everywhere else went up, and yet they went down in the pilot units. So with that, now we are moving to our emergency department in our academic medical center for a surveillance pilot. And the idea is that we will do the same as we just did on the floor units or the step-down units, where we will do surveillance. We're going to start with surveillance. We've changed our best practice alerts a little bit. For our very high-risk patients, we now have taken all the questions away and just literally say, if you're getting this alert, you should order a lactate on these patients. Because even if it's going off for some other reason, they're probably really sick and probably need one. So that's for the very high risk. Because we couldn't adapt the BPA to, the BPA only works when you're in the chart. You have to open the chart of the patient and it pops up. Because we couldn't replicate that for the list that I talked about, we had to come up with a similar strategy. So what we did was we created a sepsis priority column, which mimics when you would have gotten a BPA, and it has we have different color schemes for that. And so, again, learning as we go, we decided that that was something that if you were a very high risk and you had if you're very high risk and would have gotten a BPA, plus you're a very high risk of sepsis, so we have all these different ways that the EMR alerts, you will get a lactate. We're just going to order it. We're not going to ask a doctor. We're not going to do anything else. We're just going to order it because that is our system protocol. And so we did that. We have now done some work on our dashboards, so we have better dashboards, because if you don't give people feedback, they're not going to, nobody's going to change practice, nor are we going to learn anything. And so for a long time, we used to do probably what everybody else did with Excel spreadsheets, like years, like one-to-one, you get it like 6 months later, not helpful. And so standardize our workflows and then enhance our clinical decision support. So that's kind of, yeah, I think that's kind of what we're doing.
We're going to hold questions. I know you probably have some, but we're going to have Q&A at the end. I want to give Wendy a chance to talk a little bit, and then we're going to come up. So write your questions down for Fiona. You will get a chance to ask them, I promise.
So hello, everybody. I'm excited to be here. So just want to... All right. And we went through the disclosures already, so I'm going to buzz through that. So I'm going to talk about some of the clinical and financial impacts, and then I'm going to go through the technology and concerns and things that you need to think about when you set up these programs. And they've talked a lot about centralized versus decentralized. There's a lot of reasons, and many people will start decentralized. It's organically how you will grow. You'll grow small to grow big. But there are great advantages when you centralize. When we started our tele-ICU, I can remember there's 3 workstations in one corner. It was not very cost effective. We were having to overstaff it just because of volume as you grew. But once we got to about 350 patients, we began to become budget neutral. So there is a great reason to centralize. You can use your resources across services. Whether we brought up a tele-ICU, we had our telestroke program, and then we brought in telemetry, and then we could bounce those resources over backwards and however which way we needed to work it. If somebody called in sick, it wasn't such a pain if you only had 3 people working in a corner. So it really made it much more workable for us. It also allows you to build those standards. As you grow across hospitals, you're building the standard for your health system, and you're working up those best practices. It's no longer anybody's, hey, I want to do it this way, I want to do it this way. As they talked about, we really want to build those best practices across all venues. And again, you get a bigger global view of what's happening with your health system. You really get to see where the hot spots are, what units are really running tight, what units are really running high acuity compared to others. You can see a better staffing view. And then we had a really bad experience of getting hit by an F5 tornado and really being able to figure out what beds we had. We could visually see that within our applications to know which beds we could ship to and quickly fill those beds as we tried to move 183 patients in the middle of the night. So it does give you a lot bigger view of what you're seeing overall. As you go through this, again, everybody starts simple, and I will tell you, start simple, start small, figure it out, figure out what that workflow is. Figure out what's going to work well, what's going to not work well. Talk to the staff on the floor and figure out what is it they want from that program, because you're going to get better adoption faster if you fill their needs. Often we come in with this idea that we think we're going to help them, and it's not the thing they wanted. They wanted this over here, so then the engagement and adoption goes way down. So you've got to be very careful about targeting that one problem that they really need, and then once they get it, they're going to give you 10 other ideas of how, hey, we need to expand here. I think you could do this. They're going to be more accepting, and you'll grow much faster. And then build on that success. So as you figure it out, you've got a solid program, that's when you start rolling to the next unit, and grow it and make it much larger. So again, we also found great value, as I said, combining those resources into one hub. And that was pre-COVID. As COVID comes around, I'll talk a little bit about what can go home and what can stay within your hub overall. And again, there's a lot of questions everybody has. Should I buy the services from somebody else, or should I build the services myself? This is a struggle everybody goes into. You're building that business case. You're trying to figure out, how can I do this? And again, trying to stay budget neutral, technology neutral. What do you do to do that? Again, it just depends on what resources. Every health system is different, every unit is different, every hospital is different. The region where you live in, what you can pull from that region, you might just not have it. I'll never forget, we started a telestroke program. We had 5 doctors that were going to cover us for 24/7. And 5 days before we went go live, they decided they didn't want to do telestroke. We don't want to be on call 24/7, so we had to go buy those services. We also found that as we bought those services and we kind of got our program rolling, it wasn't that we needed to pay the high cost of the service provider, but now maybe we can cover the days, give quality of life to our providers, and then let them cover the nights and weekends. So it was a great balance to bring that back around. So it was a big con for us to be able to give that intensivist who lived in a small rural community. We got an intensivist to a small community. They didn't want to work 24/7, 365 because there's nobody else that lives really in that area. So this way they could work Monday through Friday. We covered their nights and weekends from the tele-ICU, and everybody was a win-win, and we kept that provider in place for a very long time. Again, not only for nursing turnover, provider turnover is very expensive. So again, looking at how you buy versus build. Building, every hospital, every health system's got different cultures, state regulations, whatever it might be. Sometimes it's better to build within. Sometimes you do have the resources, so it's better to build within and leverage what you have. Again, you know your staffing tools, your processes, makes it very easy to build and figure out where you can pull from and what you can use and use that budget neutral approach. Again, lots of staffing opportunities. Those staff is burning out. So what if you mix it? Give them 4 hours or 12 hours in the hub, 2 days a week, and 1 day out on the floor. So you balance that load. But we also found that many of our providers, it was about a 60-40 split. They could do 60% virtual, but they still wanted to get back to the bedside. They still wanted to do the procedures. So again, there was a balance that we found in that whole process. Again, the cons, if you've never brought up a program, you don't know what you're doing. You have a lot of questions. You're searching, you're looking at all the data that Teresa put up there, trying to figure out what is the best approach, how do we address this? So again, takes a little bit a longer time to implement just because you're trying to figure it out. That's where sometimes the con of bringing that provider service in, if you're in a hurry to get that system up and running fast, 2 to 3 weeks, which we often hear, then you might need to go with that provider service temporarily until you can get to a state that you're ready to go and start to backfill with your own staff. And again, the other big pain of this is if you start pulling bedside staff to build your virtual hub, they're going to get angry. They're going to get angry because you have taken the one last resource that we had. Nobody's there to do my VAS anymore because I just pulled that person to be a virtual sitter. I'm angry now because now I'm left to do primary care on all my patients because you pulled that resource. So again, it's another way that you've got to be very careful about how you're balancing it between both sides and to make sure that you're not antagonizing because you're looking for adoption. And adoption is going to allow you to grow and expand. Again, as you look at these services, there's other things to think about. Hybrid model, like as I talked about, just covering nights and weekends, those hard to cover shifts. Bring in consulting services. Maybe if you don't want to buy the provider services, bring in that consultant to do it the right way the first time so that you build in the right processes, give you ideas on better ways to do it, better ways to think about it, whether it's IT, networks, looking at, our networks these days in the hospitals were never built for 24/7 continuous video monitoring. They just weren't built that way. So you've got to spend time to look at that because, again, the reliability of the system, that provider or that nurse that's going to do virtual care, they expect that camera to be on every time and ready to go. And if you're not building that network and infrastructure around that, you're going to run into troubles. If it doesn't work the first time, they're going to usually check it off. Nope, that's not going to work. I'm never going to try it again. So we went through a lot of those struggles. Again, building internally. Again, leverage your resources. As they talked about, the light duties, the ADA staff, anybody that you can do, pull your retired nurses back just for 4 hours. They might just be bored and want to get back and just have a little bit of a touch base and still be able to help patients. I had one site from a virtual sitter perspective that made me really nervous, but they went and hired a group of staff off the street, college students, retirees, and brought them in to build their virtual care staff. Didn't use patient care techs, didn't use CNAs. Thought, oh my God, this is going to be a little nerve-wracking. We did extensive education with them, but they're probably some of the best sitters I've ever seen. They don't have the yin-yang between I want to be at the bedside and I hate sitting in front of this monitor. So it gives them the ability to really help people. They feel good about helping people. They're not having to smell or deal with all the bad things that you have to do at the bedside, and they love what they do. So this was a great way, and then I didn't pull away from those CNAs and techs at the bedside. I kept that staff there, kept those direct caregivers going, and it was a great way to go. And then again, offering those various shifts, because you can do that better virtually than you can do at the bedside. Technology considerations. Some of the big things really that as you go in, there's a lot of technology out there. It's a red ocean of technology. But the things that you have to think about is really the ease of use. What's going to make it easy? Is it mobile that I need to move it to the room because I can't wire every room right now? Is it a mobile tablet because I don't have time to wire? We're in such a need that I need to use a tablet at least to get off the POC or the point of proof of concept so that I can get started, validate that it's going to work so I can build that business case future. Wall-mounted systems are always hardwired. They're always probably the best way to go, but nobody's always got the time to do that. But if you can, especially in the most critical places, is a great way to go, that you always want to be able to get to that camera and that it's always on. Integrating with the TVs. Everybody's looking for that wall space. There's not enough wall space. So how can I integrate the video with the TV and condense that into one thing instead of having multiple monitors, multiple cameras, everything everywhere? So again, being able to integrate. And then BYOD. There's a lot of things you can do with BYOD. You can do admission assessments with a tablet in a room. We've got several customers doing that right now just because they needed to get up. Them so bad that they needed to be able to bridge that gap. Again, other things that you need to think about. Two-way audio video is key. People want to see your face on that screen. The patients want to see the face on the screen. They don't want to think somebody's creeping in on them and spying on them. You want about Wi-Fi versus hardwired. There's different use cases for each, so you need to consider, what is that use case and why would I go one way or the other. Night vision is key, especially when you're looking at continuous video monitoring, or if you need to keep the patient resting, but you want to zoom in and see that drip or the vital sign monitor, those types of things. Being able to invite participants at a moment, being able to invite that guest, whether it's another clinician, because I need a rapid response or an e-response based on that sepsis, or I need to bring that family in for a palliative care visit. And then just a way that the bedside can call you versus having to pick up a phone or dial a number, having a button that you can hit that gives an electronic response to your virtual hub to say, hey, I need help in this room right now, is also another key thing. And then again, you have to think about proactive monitoring and remote management of your fleet. How do I know, if I get thousands of devices out of there, how do I know what's on, what's working, what's not working? It gets old. I was on call forever on nights with telestroke cards and them not firing up or the battery being dead, or it's painful. So you want a way that you can proactively monitor and manage all that fleet. Workstations was very challenging for us in the very beginning, especially with our telestroke physicians who, it's acute time, they need to get in fast. One of the first things that we found out that we provided our physicians to be able to use their computers at home, but we were not bonded to go into the home as an IT person to set up those computers. I was bonded as a director, but my IT department was not bonded. So there's weird things that you have to think about, but you do want them on a hospital PC just because of all the cybersecurity and compliance issues. Home internet setup is fine for most things, but it is not good if you are a direct caregiver. You don't have the backup of dual internet, battery power if the power goes out. If I'm a direct caregiver like virtual observation, telemetry, I'm that direct person caring for that patient. I need to be in a hub and I need to be supported by IT. Virtual nursing on the other side, they're a second layer. So that group, if my internet goes off for a little bit, I'm not going to hinder the bedside. It's going to hurt a little bit, but it's not going to be that I'm going to let that patient fall because my power or my video went out. So those are things that you have to think about when you're trying to decide, does somebody live within your hub, or can they go home and you can work from anywhere, or you could hire those people from anywhere. Again, leveraging your secure chats, as they talked about, nurse call systems, whatever communication systems you have to use out there, you need to leverage as much as you can so they can chat back and forth between. Because it's always not that you're going to find them in their room. There are things you're going to say, hey, just got the lactate bag. We need to take a look at this and can we talk about it together? So just other ways to do that. And then expanding that reach. With the camera, you can do probably about 80% of the things that you need to do. But there are things that I need to listen to heart sounds or lung sounds that I can't do from a distance. And often, as virtual caregivers, we trust what the bedside documents and we go off of that. But now many tools are out there that you can actually hear the lung sounds and heart sounds from a distance. You can, the remote patient monitoring is giving us all kinds of data. You got the consumer grade monitoring that's coming in, also giving you trends and data. The wearables and the sensors are making life much easier. Thinking about everybody going around to collect vital signs. How much time does that take to wheel that cart into a room, take the vital signs, go to the next room? That's a lot of time. Wearables solve that problem, give you time back, give the bedside time back to take care of patients. And then clinical decision support, like we've talked about with sepsis, stratifying your patients, determining which patients need what level of technology is also key. And then AI. As we get into AI, it's becoming the new hot topic, the new great thing that everybody thinks is going to solve all the issues, but I'll talk about that in just a minute. But then also your interoperability. You've got to make it as simple as possible. When we first started TeleICU, I probably had 20 different logins for everybody's EMR, for everybody's X-ray system, for everybody's centralized telemetry. So you really got to look at how can you make it simple, and everybody has spent millions of dollars on their medical records. So they want to do everything within one medical record and keep it all living there. So make sure you're looking at login, SSO, Active Directory management. Can that interop with that? That clinical decision support being in the EMR or layered on top of the EMR. HL7, definitely getting that data flow back and forth where people are not using paper and manually collecting data or faxing data. And then data capture for reporting, because reporting is key. You need to build your reports before you start your program so you know where you started and you know where you're going. And then just leveraging, again, those communication tools. Those communication tools are getting even more smarter as time goes on. Being able to leverage what we call PCD and BCD 3 and 4 alerts, which are your code blue alerts, or your often the alerts you hear on the overhead. How can you send those into a rural hub? Because often those rural hubs don't have any idea that the code went on because you call it overhead. They have no clue. They see the vital signs go off the monitor. They thought, oh, maybe the patient just popped a lead. And then all of a sudden they're yelling at you, why aren't you in the room helping us because we have a code. So giving as much data into that the group as possible to be able to see what's going on the ground without somebody having to do something. And then just again, overall, the program considerations is really looking at technology. You got a HIPAA, cybersecurity, EMR integration, APIs, whatever applications you're bringing in, what can you interop with something else, because nobody wants to manage 2,000 applications. Again, centralized device management, that fleet monitoring, the ability to understand bandwidth, network, Wi-Fi, all those issues. Clinical workflow support is key. Understanding what the workflow on the floor is and translating that virtually and trying to make it seamless or mimic that workflow on the floors. Patient clinician friendly, it has to be easy. They can't have to go to 10 clicks. We're always counting our clicks. How many clicks does it take me to do an admission assessment? How many clicks does it take me to get here? The more clicks it takes, the less you're going to get adoption. So clicks are highly important. Impact on clinician and patient training. Nobody's had time to train during COVID, and then they couldn't be in rooms to do training because that was not allowed either. So looking at interactive models to do training on the fly, much like when you open up a new app on your phone, it says, hey, look, there's these 10 new things that just happened. So how can we make that more real-time and interactive versus having to go to a classroom or learn an LMS, which nobody has time to do? Real-time program details, knowing what's happening in that dashboard that gives you that real-time status. You need that along with the reporting status. But sometimes I just need to know what's going on. What are my hotspots? Where is it happening? How do I load balance what's going on the floor with the virtual team? And then just having that simple same user interface, whether you're going from hospital to home, because many of our providers and clinicians jump from one environment to the other. And then from an administrative support is really looking at hardware. Is it a capital purchase? New thing right now is subscription models. So instead of having to buy it, how do I go into a subscription model and I get that refreshed every so often versus having to buy it every 4 or 5 years? Program costs, Again, you have to look at, when I buy that, what is the cost at 1 year, 3 year, and 5 years, because it could be very different. You're going to see a very different ROI as you come out, as you look at that over time. Phased approach, again, start small, go big. Avoid ripping and replacing. Use what you have, leverage what you have, integrate whatever you can with what you're doing before you start buying and building or just replacing everything. Again, you have to think of the long term. I will never forget, I did my first tele-ICU. We had 350 devices out there. Year 4 came around. We had no end-of-life program. So I had to ask for $4 million to replace 350 devices at a moment's notice, which was terrible. So don't do that. Plan for the end. Plan for that rotation. No, you're going to have to think about that at some point. Look for grant opportunities. So many grants out there supporting at least. We did a lot of our program startups with grant opportunities. The HRSA grants and the USDA grants are awesome because there's not a lot of reporting to it. You can get the devices and systems that you need. You can get up and running and go on. And then again, automated program dashboards. You've got to know how that program is performing to know that to ask for the next program. You have to be successful and be able to really give that measure of success so that trusts you to go with the next program. And just to touch a little bit on AI, we've done a lot of machine learning in the last year and a half, trying to understand what can a camera do or what can a camera not do. As we've gone through this, we do know that as you go into AI, cameras have to be in a fixed position. So if you're thinking of using a camera for televisits and then you're thinking about AI, that camera has to stay in that fixed position. You cannot be moving it around because how it does its machine learning is that fixed position and what's happening in that room. Solutions are often proprietary and don't do the whole telehealth kind of concept. So you need to think, do I have a camera for this? Do I have a camera for that? Do I have a camera for this? Now you got 3 cameras in the room, and who wants to go to sleep with 3 cameras in the room staring at you all day long? And then I think it's also, as we get along into this, staff are going to get very nervous about all these cameras being in the rooms. They hated it in tele-ICU to the point that I had them putting their lab coats over the camera, Vaseline on the lens, because they didn't want the camera to look at them. So we've got to be really cautious and think, clearly about how you're going to use those cameras. AI and the machine learning, it's pretty primitive yet. It can't predict. It will tell you that somebody is out on the floor and on the bed, or if they're up and out of the bed, but it's not going to tell you two to 3 minutes before that happens. So you're going to get that alert. That alert is often going automatically to a text message. I now, in isolation, can't touch my phone. How do I get that text message and get down the hall and rescue that patient before they fall? So just things to think about. That false alarms that Teresa brought up with 178,000 alarms, this will only increase as AI until it gets smarter and better to be able to predict. Again, as the patient moved underneath the blankets, it can't tell that the patient's leg has gone out of the bed underneath the blanket. You can't see through the blanket. You can't see lines into the drains if they're under the blanket. So it's still got some challenges there. And then again, it's a setup for that kind of setting all those alarms, just like your bed alarm. Nobody wants to go chase those alarms all day long. There's not enough staff to do that. And then how do you report on that kind of false alarms versus what is real alarms? How did we rescue type of thing? So just things to consider with AI. And that's me. I think we're back on track. So now we're going to open up for questions.
Yeah, so we're going to have you guys come up and grab a mic. Do you want to grab that mic right there,
Sure.
Wendy? All right, the 2 shortest have to climb up gracefully. They had the short chairs up there, and I thought, well, they'll never see Wendy and I. We're sitting in a low chair. All right, so what questions do you all have? Has this been helpful?
Very. I think,
Right.
I'm thinking about, what am I going to ask? What am I going to say? And I have to be honest, this is probably one of the most beneficial sessions I have sat in for any conference I have ever gone to, nursing, telehealth, whatever. This has actually spoken to me in this time that I'm in right now in what I'm doing at work. So thank you, and I think it was a really great session. I don't know if anybody else agrees or disagrees. I don't really care. But for me, I thought it was really great, so thank you for putting it together and
Yeah.
spending this.
Well, thank you. Thank you.
Out of curiosity, I would hope by now, you know, Teresa, we've been at this a long time. Do you know it is a virtual nurse component pretty much in every state now by some entity or anything, or is it still sketchy and just in certain regions?
Well, telecritical care, when I did my dissertation, was in 40 states. And that was from, the data I used was from 2010 to 2015, and it's grown since then. So I'd say we're getting close to being in all 50 states at this point.
And how did you see it moving into like your acute care and your chronic care? I know tele-ICU was where it really started, and the tele-ED came along, and all these factors, but I would hope to think by now that we are using it a lot more advantageously in the acute care setting, chronic care setting. There's just all kinds of places. Are you?
I think that's where COVID helped us, right? Because we had to learn fast. And so for our institution, we got a lot of grants, like Wendy was saying. So we actually deployed in a lot of our med-surg areas, which is why we were able to do the project that we were doing, because I probably didn't say this because I implied it, but we can do this with a computer. But the problem is that we all know that sometimes people don't put vital signs in correctly. And so our rapid response team and our virtual teams spend a lot of time answering alerts because data was incorrectly entered. And so they're fixing that, which goes to that. We just burdened the bedside with this when we could have taken that burden off because it was an error. And so for those of you that are looking at continuous monitoring, that's something we're looking at. We've piloted a couple of solutions. It all feeds into the same thing. We're making errors by, as Teresa calls it, fat fingering, right? Yes. We fat finger things, and we actually create errors by our manual data entry. And so I think it's spreading. I know we're looking at hospital to home programs, and I'm sure these guys can speak to the same thing. So I think we did televisits. I'm sure you all did the same thing in your clinics. We would have not had clinic open at all through COVID if we hadn't have done televisits. So I think that's where we got helped.
My last question. Get ready. Are there any nursing programs, any, that actually have a part of their curriculum dedicated to the use of the technology, when to use it, just this foundational telehealth 101? Is it in every state? Is it in a few programs? Tell me it's growing.
Well, we have someone in the audience who has a program. I'm familiar with that program. So do you want to tell us about what you guys have done?
We've been teaching, so I'm from Old Dominion, and we've been teaching telehealth to some degree for 10 years. And we embedded it initially into our nurse practitioner program. And then when COVID happened, we were, the medical school around the corner reached out to us and said, oh my golly, our medical students don't know anything about telehealth. Help us, help us, help us. Our residents can't, our fourth year medical students can't go to clinical, and our attendings at clinical don't know how to virtually mentor them. So we quickly developed a course for them. They all came through our course. And now fast forward to where we're at, we have a 2-week certificate program offered to anyone in the United States. One is for providers and educators, realizing that educators don't know how to teach telehealth because they haven't done telehealth. You know, so how do you teach something you don't know? So they come through the curriculum with their students. We then developed a presenter course for the undergrad students because we realized the undergrad students are the ones that are doing everything you're talking about and remote patient monitoring, and we do have equipment if they come on campus. We purchased all the equipment so they touch it, they play with it, we run hackathons. And we just finished a behavioral certification class, realizing that that's a different beast than providing or presenting. And so it's offered, so we have embedded it throughout our curriculum. One of the chair of the graduate program wrote the NOF white paper, you know, so in the toolkit.
I said on one of your presentations, I still have the slides from it. When you started the 2-week and you were making it and so I go back, I'm really old, but.
And so our hope is that when a faculty member comes, they learn the content, but they also get deliverables that they can take back to their own courses, to build out courses.
Any of the same goes to me.
Yeah,
I've been at it really for a long time, and they're great. I will say that, and you've done a great job, and I'm really been impressed by them. But please tell me, they're
Valparaiso in Indiana used to actually come pre-COVID to our site as one of their elective opportunities to come for clinicals. So that was the undergrad nurses. And at one point, we had critical care fellows working in our tele-ICU from one of our county hospitals. So unfortunately, that went away with COVID, but it has been done.
And I would say go back to AACN because they've just written out the new, the new competencies and whatever you want to call them, that are threaded from undergrad to master's to doctorate. And they did not speak specifically to telehealth, and I think that was wrong. They spoke to technology. So as as a school, you can pick what you want to teach with regards to technology. And the students are getting out not knowing how to do this. And,
Right.
And they're not getting it in a clinical practice when they go to the clinical
And I can tell you
site.
for a fact, I stopped teaching. I stopped being a faculty full-time. I went adjunct in 2019. That was about the time things started to ramble. And from 2016-19, I absolutely beat my head against the wall. I decided, okay, I'm too old. I can't do this. Give it up. Something else will do it for me. And it did, because it came along. Because I'm faculty that absolutely, and I'm not going to do false swear, but the first thing that surprised me, they were still teaching medication administration with a paper chart. And when I said, well, but they don't do that anymore, and I had students that came in, we went into clinical site, and they're going, but they don't do it that way. No, they don't, but it's still a good thing. Let's just still learn how to do it. And then I got really brave, and I found a little computer, and I put it on a med cart, and I took paper, and I drew it up, and we pretended, and my group had fun with it, but then I got caught on the carpet because my group had too much fun with it. And how do you do a barcode scanner? At 2019, when I went adjunct, none of that was taught. They did not teach documentation. See, it was like, well, the EMR does it. Well, okay, I know it does, but do they know what the gone? You know what I mean? It's not going to magically put it in there for them. Well, of course not. And I meant with resilience, and that was when it came out that the curriculum was going to be changed to special community colleges, and they had to include technology. And I got excited. I thought, okay, this is what they'll have a place where I just teach this. I'm so excited. And I was told, no, they learn technology. They do Blackboard and their emails. And I'm thinking, I don't think that's the type of technology. But I've been wrong before today. So after 2019, where I had now become adjunct, and then I truly at that point I was in the blessed position. I could give up and let other faculty that really needed to work and help them. To only have 3 of the oldest faculty retire.
Yeah.
2020. I wonder.
I do think it's an opportunity, though, both for the providers and for the nurses. We definitely do it when they reach us on the hospital side. So we do have them come in like their orientations and things like that. We do go out to them when we initiate a program, probably like any of these guys do. We don't have this is the bunker or this is the telemedicine area, this is the floor. We actually go to them, and because it's a collaborative. Usually the problems start there at the bedside, and we're here to solve a problem. So it's a collaborative effort. We've had the same thing, fellows, providers be in our bunkers, and I think we're going back to that. I think we've learned, and again, where COVID has helped us, is that we can do a lot of things actually better if we're not running around like crazy people in the hospital. We have 16 floors. Our elevators are not that good. So we actually can move faster if we can just click from one room to another than if we actually have to run around. Like, that's just wasted time and energy. And so, we think, you're doing virtual things, and I think that's been a theme here of what can you do at the bedside and what can you not. I can tell you, I can go to rapid responses far more rapidly through a computer than I can if I'm using my legs.
Yeah, and most of the nursing informatics textbooks do have at least one chapter on, well, they usually have multiple. They'll have one on telehealth, they'll have one on digital health and the Internet of Things, those things that all kind of wrap underneath the broader umbrella of telehealth. So we are starting to see that.
You think they'll start embracing it more and pulling it in, or is it still have to?
Yeah, they have
They
to.
have to. I don't
Yeah.
think it's.
I have a question, and it's probably a silly question. So everything you're talking about is adult medicine, and I get it. And I'm wondering whether you have a model for pediatrics. So I have a pediatric cat, and you know, people think they're very different than adult people. And so to take this model to administration of a pediatric hospital to pitch this idea, I mean,
Absolutely.
We actually have what's it called? Telestalk for the very, very littles, like the NICU little
Yep,
people.
tele-NICU.
I think there are some programs that are pediatric. These guys probably know. But
oncology units.
Yeah.
You know, those kids are about as sick as they are. They're 2 steps away from an ICU.
Yeah.
And when you've got brand new nurses in a HEMONC unit.
So I'll put a plug in. I'm a guest editor for Advanced Critical Care, which is an AACN journal, and one of the papers that will come out, won't be till November, is from Children's National, and it is on pediatric telecritical care and pediatric virtual nursing. So they're writing the paper right now. I should be getting it in the next week, and then it'll go for review, and we'll get it through the pipeline. So yes, there are many groups now doing that. If a lot of it started in more of the medicine side, like the great work that Jim Marson did out of UC Davis with pediatric ICU, keeping patients in their home hospitals and providing those intensivist services over telemedicine carts. So that's where it did start the most. But yeah, we're starting to see it all over pediatrics, specifically, and also pediatric behavioral health. Lots of use cases there.
I see the support of the bedside nurse. I'm really intrigued by that.
Mhm.
You know, they're babies and they are novices and they're lost.
Right.
And that's where I see a real benefit.
Definitely.
Relationships, especially because I had a daughter that was at Children's years ago, immunosuppressed with an oncology problem, but they are so fragile too. You know, you don't want to take them out, you don't want to drain them in. If you can limit that exposure, it's so much better. So learning how to pull that in and come and do it would be.
we've been doing palliative care too across the continuum. So that's something that can go from hospital to home, and again,
Right.
COVID helped us there too. So that became more
And
kind
we
of
were doing
acceptable.
palliative care into the SNFs as well.
Yeah.
Over
Yeah, and
virtual.
we're recently working on a new kind of NICU camera because a lot of the cameras out there are more for the grandparents or the parents to view, but how do you get in there? How do you attach it to the wall and not fall on a baby and kill the baby because it's so heavy? So we're really looking at the angles and the directions and how that needs to be done. Because definitely different.
Other questions? Mary?
I have a question about the staffing. I thought it was brilliant the way that you looked at, first of all, budget neutral is always good.
That's the
Yes.
word.
Yeah. Is that I loved that looking at areas that had long-term vacant FTEs or those, but like once you proved that, like I guess my thought is the goal a way to have fewer nurses in person, or because it does I'm like thinking of my financial hat, which I don't usually wear, is like we're doubling up on staff.
But-
So, I mean, it's
Yeah.
not totally, it's not
Mhm.
like every in-person nurse then has the virtual nurse, but how do you?
Well, we did that in California. We have mandated staffing ratios for
Well, you
every
said
floor,
California, that
right?
was
So we did not replace staffing. And when we
until
started our
ICU was built that way.
Yes,
You
all
never
tele, yep.
replace staffing, you were second layer, but every hospital I'm interacting with right now, it's not that you're replacing it, but if I had a complement on a floor of 5 nurses, somebody calls in sick, there is no replacement. You put the virtual, it is budget neutral. You're still getting down.
Budgets are trying to figure
Yes.
out, trying to figure out my head.
And another way of saying it is, so we'll say, okay, so you nurse at the bedside, we just went to 1 to 6 in med-surg as a routine, which we use on our med-surg, our step-down units are pretty much the same now, like they're all just med-surg. ICUs are 1 to 2, probably going to be 1 to 3 on any given day. sometimes 1 to 4, and we don't have the break rules, we don't have unions, so if you go for a break, that means you're watching your whole hallway, which is 4 patients, or if you get called somewhere else. So the other way that we've looked at it is how many people are you watching, because it's not a one-to-one, right? So like our rapid response team is, we have 2 nurses for our entire facility, which is 500 patients, so that's 1 to 250. So what is our nurse-patient ratio for our virtual nurse? It's usually 1 to 40 for EICU is what they're watching. For med-surg, they're watching much more than that. Mm-hmm. So we have 1 nurse watching right now about 700 beds, essentially using technology. So that's a 1 to 700 ratio. That's pretty good. Mm-hmm. That's like the best thing that a CFO might want to hear.
Do you
Okay.
find
I want to get one more question in real quick because we only got 2 minutes. We'll stay here.
Yeah.
And we'll be at the reception. You can grab a cocktail and bother us too. We'll talk forever.
That's right.
But I want to get your question.
It was just to elaborate on the nurse
Okay.
ratio. Our system spends a lot of time thinking about that. So then are you measuring live nurse ratios and then not present nurse ratios? Are you blending those things in as you present this information?
I think you can look at it different ways, right? And it's all in who's hearing the conversation, because I wouldn't say that to our bedside nurses, because they would be quite upset. But the fact is, when you're thinking about who your audience is, you have to think about how you're delivering the information to get the resources that you need. So and I use rapid response because that's one of the things that we've spent a long time working on. And it works the same way kind of with our virtual nurses is, okay, well, you could hire a nurse for every unit to be the surveillance nurse or the support nurse or do all the things that you're doing. But I can hire 1 for 5 hospitals instead of hiring 1 for every floor. So you pick which one you want.
Right.
And I can tell you which is easiest.
Real quick, I just want to say, it depends on the problem you're trying to solve. We
Yes,
talked about at the beginning.
exactly.
If they're doing admission and discharges, how long does it take on average for someone to do an admission or discharge? Times, right? The number of patients you want them to do is the number of hours you need that nurse, and then that will drive your FTE number based on how much volume you think you're going to do. Now, someone else would be doing that task, and they'd be getting interrupted constantly, or it wouldn't get done properly because they're being interrupted. So again, you can make it budget neutral depending on how you spin it.
I think it's looking at hours per patient day, but you include the virtual hours and the direct care hours, and coming up to those hours per patient day is what you're really looking for.
Yeah, I think you also have to be careful in
That's how I would look at it from my
I think you also have to be careful, and we've made this mistake. So just like your lessons learned, we can overtax the resource, and then they can't get the job done. So if you're asking them to do emergency response things and surveil all these patients for sepsis and do admit discharge, they're not going to be able to do it. It's 2 different jobs with 2 different skill sets. So back to the competencies, you need to have the right competencies doing the right job. So I would not ask our ICU people to discharge people. That is not in their skill set.
That's right.
That is not in my skill set.
That's right.
But I can tell you, the med-surg nurses that are doing ADT in some of our other places, I would love to be discharged by those people. They are doing a fantastic job. But
really
it's
good
the
at it,
right skill set
It
for
is.
the right job.
But I also think we're seeing various types of programs out there. So if you just have an admit discharge program, it's a very different model than just a surveillance model or a rapid response model. We know that one person doing admissions, face-to-face admission takes you about 25 to 30 minutes. We've seen the virtual nurses get it down to about 14 minutes, and they're very good at it, and the quality of the admission is greater than it is if I'm being interrupted 5 times. I got to go back to the room 5 different times to be able to complete that. It's a much different picture. So again, if I'm an admission nurse, it's going to be a whole different model. It's how many admissions can you get done in that 12-hour period, going from room to room to room to room. You're going to get good at it, just like a telestroke doc.
Quick question. So are your nurses happy? Not your bedside nurses, but your tele nurses. Are they happy and are they staying?
Ours love it. In fact, ours
I'm
are
never
arguing-
going away.
Yeah, our bedside nurses love it, and so when they don't have the support, they're like, "What happened? Why don't we have this?" And then, interestingly, our nurses that have been doing our surveillance work, because now we have our EICU doing that, they're fighting for the job because they get a lot of good feedback from, oh, thank you so much, that was super helpful. Like, it's a new thing, and so it's like, I'm like, wow, we're creating this whole like frenzy of people that want to do the work, so it's great. And
so
I guess
we are over time. Anyone who needs to leave can leave, but we'll stay. So did you have another question, because I cut you off? And I'm sorry.
My question was, do all of you tend to have like a central hub in the hospital for the virtual nursing, or do people work from home? Like, what is that?
all of the above.
We've seen
all of
both.
the above.
Yeah, we've seen, especially during COVID, because
Everybody
they
went
needed
home.
they needed to spread out, right? They had to be 6 or 8 feet, so they would allow some of their staff to work from home, but they have to have sign an agreement and a contract that they're going to have a private space, so it has to be a HIPAA compliant private area to do these visits in. They have to ensure they're going to have the right internet speeds and redundancy so that they can continue to practice. And then they go home with work-issued devices, as Wendy mentioned, so you can ensure that they are going.
Kids are not allowed to use it, and nobody else is allowed to.
No one else can touch
This is a
this.
special. I got yelled at by so many physicians' wives because we were putting a second computer in their nice and fancy office space because they didn't want 2 computers. Yeah, no. This has to be hospital. This has to be work. Whatever.
Yeah.
So we made sure that it was
So
dedicated.
we've seen it from both physicians and from the nurse side and nurse practitioner side, working remotely. Mhm. Yeah.
Again, as long as you're not the direct caregiver, if you're a virtual sitter or your telemetry, there's no way that
Right.
technology
You have to-
requires
yes.
such a higher
Mhm.
level of computer and redundancy and that kind of thing, so you don't break or make an unsafe situation.
Right, and for our telestroke programs and our programs like that, they can do the visit from home, but they need to be able to get somewhere if they're, if they lost power and they don't have internet capability, they have to get to the hospital, to their hospital office within 30 minutes, 20 minutes if possible. They can manage some of it on the phone while they're going in, but then if they have to go. So they know that, that's part of the contract.
Yeah, and you got to build those
Mhm.
expectations when you build
Right.
that program out. And there's also trackers like how many clicks and are they clicking on their keyboard to validate that they're really doing the work that they need to be doing
Mhm.
and not shopping.
Yes. Other questions? Well, thanks for hanging out longer and for hanging. Oh, go ahead. Got another one. We'll stay.
I was just going to say this one great.
Oh.
Thank you so much. Thank you.
Okay. Yeah, it's an all-star panel here I got to talk with. I put this together and I'm like, I know who I'm calling. They're all my friends too, so it was easy to talk them into it. All right, thank you guys.
Because I'm not a nurse.
Mhm.
I was very interested in what you all do.
Oh,
good. Well, thank you.
And I look up there and I say, all the knowledge that's before, and all the skill set, different skill sets, and the ability to work together. Oh, this is fantastic.
Thank you.
Well, that's
Thank
what we
you.
have to keep. So
Yeah.
we're working for our own interests too, right?
That's right.